MD in General Medicine. And sir has also worked as a senior resident doctors in Nigrims and also assistant professor in Lady Harding and also associate professor. Sir, currently sir is working as an associate professor in Nigrims, Meghalaya. So sir has a passionate about teaching and also sir had trained in medical education and his area of interest is infectious disease, rheumatology, and has been now subbed in an ethics in Nigrims itself and also organize the Secretary Meghalaya State in chapter in area, and then also been a faculty in charge of medical critical care unit in Nigrims and had done more than 70 publications in national and international journals. So this was the brief introduction of our first presenter. So our second presenter is Dr. Vijay Nolsar. Sir is currently working as an assistant professor in Department of Tuberculosis and Respiratory Disease in Nigrims itself. And sir is also this is nodal officers of COVID. And sir, I've done a doctorate of medicine and doctors of medicine in postgraduate from AIIMS Delhi, and I've done MBBS in Zipmor. And sir is also a member of Indian Chest Society, European Respiratory Society, and Meghalaya member Meghalaya State Drug Resistant Expert Committee, and has won many awards and honors in from the Zipmor also and from NCRT also in year 1998 in 2004. So welcome you, sir. So we have a next presenter, Dr. Rosina ma'am. I think most of the people who have joined our PICU training are well known by ma'am, Dr. Rosina ma'am, because ma'am has actively participation in our 1 month PICU training. So ma'am have done MBBS from the Lady Harding Medical College in Delhi and have done MD from Simla, and currently ma'am is working as an assistant professor in Nigrim and has also been a SNCU nodal officer in Nigrim, and currently ma'am is a secretary in IAP Meghalaya 2021 and also a NRP FGM instructor. So this is a brief introduction about Dr. Rosina ma'am. Ma'am, welcome, and thank you for being a presenter of this session. Next, we have Miss Hatneling Simpe. Ma'am is a nursing officer and has completed her master's in nursing in OBG from West Bengal Government College of Nursing in 2013. So thank you for being with us. And our last presenters, we have Dr. Mary Dev Burma ma'am. So ma'am has done MBBS and DNB in family medicine and currently working as the head of EMLC Department of Ziviki MRI Shillong, and also involved in co-facilitating many postgraduate diploma in family medicine training program with the distance education department of CMC Vellore. So thank you for joining with us, ma'am. So these are the brief introductions of our today's presenter. So now we want to move ahead with our agenda. So for this first, I would like to request Dr. Bhupen Barman sir for the presentations on hypoxic management in pregnant women. Over to you, sir. Sir, you want me to share the screen? Or you?
I'm trying.
Sir, can I share your screen?
Yeah. Can you start from your side?
Okay, sir. No problem. My screen is visible.
Okay, I'm sharing from my.
Okay, sir. You're sharing? No. Okay. Sir, actually presentation is not visible.
Okay.
Yes. Yes.
It is visible, sir.
Sir, now it's visible.
Now it's okay?
Yes, sir. Yes, sir.
Okay.
You just do yes. Perfect.
So good afternoon, everyone. First of all, I would like to thank Nanuka and her team, Dr. Wansa, Ananda, for giving me the chance to be part of this wonderful webinar program. Let me start with a small story. 70 years back in 1942, a 33-year-old lady was suffering from severe streptococcal sepsis in New Haven, Connecticut Hospital in New England. And despite the best medical effort, her doctors could not cure her infection. Then they managed to obtain small amount of a newly discovered molecule called penicillin, which they cautiously injected into her. After repeated doses, she cleared of streptococcal infection, and ultimately she went to live up to the age of 90 years. 60 years later, in 2010, a 70-year-old male in San Francisco was reported with endocarditis caused by vancomycin-resistant enterococcal infection. Despite the use of best antibiotics available for combating the vancomycin-resistant enterococcal infections, physicians were unable to sterilize the bacterial patient, and he died still bacteremic. So even in the 21st century, with all the development of the modern medicine, we arrived at a point as frightening as the pre-antibiotic era. There is no magic bullet. Last night, while I was on duty for COVID in level C, and I was wondering, like, it's ironic to be reminding ourselves that we don't have magic bullet for COVID-19. With this, I'll start my topic. The next 20 minutes we'll discuss on management of hypoxia in pregnancy. This is a very fast topic, and I don't know how to formulate this everything concisely in 20 minutes. So still, I'll try my level best to complete some of the basic notes on hypoxia in pregnancy. Not have to go to next slide.
Slide is not moving.
Slide is not moving.
Yes, sir. Can you click? Can I share from my side, sir?
Yeah, I think better. It's not moving. I don't know.
First one. First one. Hypoxia. First. So now we have started sharing. Screen is visible, sir?
Yeah, screen is visible. So my learning objectives, I'll try to first causes and classification of hypoxia briefly, and some of the respiratory changes both in anatomical and physiological during pregnancy, cardiovascular effects of relevance, some important pathological states which can result in maternal hypoxia, basic investigation, not in details. Cornerstone of therapy is oxygen therapy. Will go through indication, different methods, precaution, and toxicity, and a few slides on invasive management strategy and for young doctors' future perspective. Yeah, next slide, please. So, as we know that hypoxia is reduced supply of oxygen to the tissues, and in pure definition, it's the reduced partial pressure of oxygen in the pulmonary veins and through the pulmonary veins ultimately to the tissues as blood comes. That partial pressure of oxygen that defines reduced level of partial pressure of oxygen that defines hypoxia. Classically divided into 4 groups. One is hypoxemic, which is the most common one, followed by anemic, ischemic, and cytotoxics. Hypoxemic one is the most common form of hypoxia we see it can be due to decreased atmospheric pressures. It can be in high altitude. It can be due to obstructive pathology, like in case of severe asthma or in COPD, non-pregnant lady or non-pregnant patients. It may be due to muscular weakness, respiratory muscle weakness due to some neurological disease like myasthenia gravis. It may be due to ventilation perfusion mismatch, like in case of pulmonary thromboembolisms. So there are various causes of hypoxemic hypoxemia, and some of them are common in case of pregnancy. Anemic hypoxia is basically it's due to deficient or dysfunctional hemoglobin. If hemoglobin is deficient for any reasons, and oxygen carrying capacity is going down to the tissues, resulting in hypoxemia, or sometimes hemoglobin levels are normal, but if it is dysfunctional, like patient with carbon monoxide poisoning, although hemoglobin values are normal, but it is dysfunctional, so that in that condition also tissue will be hypoxemic. In case of ischemic and stagnant hypoxia, basically there is obstruction to the arteries or veins. You can divide into two categories. That can be generalized ischemia due to poor circulatory state, like in patient with severe congestive heart failure, where tissue oxygen supply to the tissues are less, or it will be sometimes localized, like if there is localized thrombus, obstruction to the arteries or veins, and in the localized areas, there may be hypoxic. And in the last form, cytotoxic or histotoxic hypoxia, patient partial pressure of oxygen is normal, hemoglobin is normal, there is no obstruction, but tissue has inability to utilize the oxygen because of some deficiency of the or dysfunction of the enzyme, classically found in cyanide poisoning. So these are the four classical types of hypoxia: hypoxemic, anemic, ischemic, or cytotoxic. Next slide, please. Nanuka, next slide. Nanuka, next slide. Nanuka, can you hear me? Next slide. Yeah. So coming to the some anatomical and physiological changes of some structures during pregnancy. Basically, there is edema or edema of the nasopharynx and larynx due to hormonal effects during the pregnancy. And in pregnancy, because of estrogen and progesterone effect, there is increased renin leading to activation of renin angiotensin aldosterone system, which can cause sodium and water retention and can cause generalized edema. So because of either localized edema due in the upper airways or because of generalized edema due to salt and water retentions, during pregnancy, especially during labor time, intubations, it's not very easy because it uh, because it can cause difficulty in visualization of upper airways, and difficult intubations can lead to maternal hypoxemia, and if it lasts for chronic durations, sometimes it may lead to uh, aspiration pneumonia. This is the Malampati course, which during intubations, the visualization of the upper airways. Class 1 is normal. In the pregnancy, it happens sometimes it goes up to class 4, which can result in very difficulty in or failed intubations results in maternal hypoxia. Next slide, please. A few parameters which changes during pregnancy is the respiratory rate, which can increase up to 20 to 70, tidal volume increased, and there is decrease in the partial pressure of carbon dioxide and partial pressure of oxygen remains normal or sometimes high. This one is important because of interpretation, because some of the time we have to diagnose or analyze based on the clinical criteria. So mild tachypnea or mild reduction of PCO2 may be considered as normal in pregnancy. Next slide, please. Regarding changes of cardiac parameters during pregnancy, Cardiac output, heart rate, stroke volume, they're all increased during pregnancies. Output may increase up to 50% sometimes, heart rate increases, stroke volume increases, and there is decrease in the vascular resistance, both systemic vascular resistance as well as pulmonary vascular resistance. And there is ideally there should not be any sense of the mean arterial pressures or mean capillary artery pressures or pulmonary capillary wedge pressures. This one again important when we evaluate a patient with pregnancy. For some, like patient is having tachycardia of heart rate of around 110, otherwise normal. So that may be considered as normal for that pregnant lady. Next slide, please. Coming to some common pathological conditions which can result hypoxia in pregnancies. So ARDS is one of the most common entity what we have seen in the clinical practice. So acute respiratory distress syndrome is a clinical syndrome of severe dyspnea of rapid onset along with hypoxemia and diffuse pulmonary infiltrates leading to respiratory failure. And there are some grading or classification criteria are there. I am not going for details of the diagnostic criteria, but clinically, when to suspect if patient is having severe dyspnea, acute onset, along with saturation of less than 90s, and if permits, if we can do X-ray and there is diffuse cess infiltrations, you can go for arterial blood analysis, and if you can see the ratio, and then based on that FO2 ratio, then you can label it as a ARDS. The most common, there are two type of injury that can cause ARDS. One is direct lung injury, and another is indirect lung injury. In the direct lung injury, pneumonia per se can cause like COVID pneumonia leading to ARDS. Aspiration of gastric contents, especially in typical intubations or delayed intubations, pulmonary contusions, toxic inhalations, sepsis for some other reasons may cause ARDS. Severe trauma, multiple transmission is common in case of pregnancy, drug overdose, and sometimes for some other reasons like patient is having pancreatitis can lead to acute respiratory distress syndrome. Next slide. Management of acute respiratory distress syndrome, it does not differ in pregnant versus non-pregnant. In both these conditions, it's mostly of supportive. The basic principle is reduce fluid transudation in the lungs and maintain the oxygen delivery. And what is more important is treatment of underlying cause, like if patient is having pneumonia, you have to give appropriate antibiotics. And if there are some other reasons, you have to treat that primary cause. What is more important here is there is no evidence that delivery improves maternal respiratory status, although early delivery may warrant it because of fetal concerns. So for ARDS per se, there is no need to go for elective CS or early delivery, but definitely for fetal concerns, sometimes you may have to go. Yeah, okay. So this is the normal protocol we follow for normal patients, like say it will be same for both pregnant as well as non-pregnant patients. So number one is targeting because all the ARDS patients we put for ventilations. So regarding ventilation management, these are the few criteria which to be followed in all ARDS patients. Tidal volume should be less than or equal to 2.6 ml per kg. Relative pressure less than 30 centimeter of water with respiratory rate of less than 35 beats per minute. Oxygenation have to maintain with FiO2 of less than 0.6, PPO of less than 10, and saturation should be 80 to 95%. Patient should not be, there should not be cirrhosis, it should be more than 7.3, heart rate should be more less than 135, and patient should have adequate diuresis, maintaining mean arterial pressure of 65 millimeter mercury. You have to avoid both hypoperfusions as well as we should not flood the patients with fluid, because many times happens that we are giving fluid and most of the patients, they do have acute renal injury. So you have to maintain input, output very judiciously in this group of patients. Next slide. Coming to the next common cause is pneumonia. Is can cause both maternal and neonatal morbidities. Mostly those who are having comorbidities, they do suffer more from than pneumonia. And some risk factors, like if you are giving steroid for premature babies, you are giving steroid and then see some prophylactic agents, they may precipitate pneumonia, and need of hospitalization increases with 8 trimesters, mortality highs. The treatment protocols same as non-pregnant lady, you have to give antibiotic therapy, but here you have to give a note that some of the antibiotics are really teratogenic, so you have to try to avoid them, like aminoglycosides and fluoroquinolone. Next slide. Okay, so this one is very important slide. So regarding asthma and pregnancy, three important questions that commonly arises or commonly to be answered in asthma with pregnancy is the effect of asthma in pregnancy, effect of drugs on the child or baby, chances of having asthmatic cells. If these three questions can be answered properly, most of the things can be dealt with. Regarding the first questions, effect of asthma in pregnancy or vice versa, it has been found that 1/3 of women with asthma improve during pregnancy, 1/3 will deteriorate during pregnancy, and 1/3 may not have any effect during pregnancy. So ultimate take home point is, you cannot predict which patient will improve, which patient will deteriorate, and in which patient there will be no change during pregnancy. The effect of drugs, most of the drugs used for asthma therapy like beta agonist, theophylline, are safe and without teratogenic potentials. But there is a point here. It is wise to confine treatment to inhaled drug as far as possible. Regarding steroid, low-dose steroid can be used safely, but high-dose steroid may have deleterious effect on the early fetus. Even low-dose steroid for a long time can have teratogenic potential, like it can lead to cleft lip and cleft palate. So try to avoid oral steroid. Inhaled corticosteroid like beclomethazones, they are safe in pregnancies. There are less safety data for long-acting beta agonist, anti-leukotrienes, or anti-IgE. So as far as possible, try to use short-acting beta agonist and inhaled corticosteroids. No clear data regarding chances of having asthmatic cells, but at the same time, no good reason for asthmatic cells not to have children. So I think it's clear, these three questions. During effect of asthma in pregnancy, you cannot predict. Drugs, most of the drugs, they are safe in pregnancy. Steroid, try to avoid. If required, you can give low dose of steroid. High dose, you should avoid. And such chances of having asthmatic cells, that this genetic effect you cannot predict. Next slide, please. Yeah. So smoking has deleterious effect, both active as well as passive smoking. So it may not be like active smoking. Passive smoking is equally dangerous as active smoking. So maternal smoking increases the combined mortality in fetal and neonatal life by 28%, reduces birth weight around 250 gram. It results from placental insufficiency due to nicotinic vasoconstrictions and also high level of carboxyhemoglobin. Active maternal smoking is more dangerous than the paternal, and if both smoke, then risk will go for 5-fold more high. And children of smoking parents have twice the risk of pneumonia and bronchitis in the first years of life. So it's always advisable not to have active as well as passive smoking. This is a rare condition. Spontaneous pneumothorax in pregnancy can happen, especially if patient is thin build, having history of asthma is mostly due to rupture of the apical valve. So treatment is as like of non-pregnant ladies, like treatment aspiration with tube drainage and surgical treatment if required. Next slide. Next slide. Regarding cardiovascular causes, all cardiovascular disease can have deleterious effect, can cause hypoxia in both pregnant as well as non-pregnant lady. What is more important here is to calculate how rich is the patient. So this is the commonly used risk index assessment, maternal cardiac risk index, with which you can estimate the risk of cardiac event. If there is prior cardiac events like heart failure, stroke before pregnancy, TIA, baseline NYHA class 4, class more than class 2, left-sided heart obstruction like aortic stenosis, mitral stenosis, LV systolic dysfunction of less than 40%. Each point carries 1 point. If patient is having more than 1 point, then definitely there is more risk. If there is more than 3 points, there is however is very less in case of pregnancy. So you have to assess the patient for cardiac assessment. Next slide. So there are two more causes, respiratory causes, which can cause hypoxemia in pregnancy. One is obstructive sleep apnea, which can lead to hypertension, pulmonary hypertension, arrhythmia, right heart failure. CPAP is the mainstay of treatment. Cystic fibrosis, it's a genetic disorder, not very common, but it can happen in pregnancy. Then treatment protocols are same as like non-pregnant lady. Only thing, this group of patients needs long term of antibiotic therapy. You have to be careful using proper antibiotic therapy without teratogenic effect. Next slide. I'm not going details of neuromuscular diseases, not possible. It's out of the time period. Like some common conditions which can lead to respiratory muscle weakness, you have to take consideration when dealing with patient with hypoxemia. One is already patient is known from motor neuron disease. Any form of spinal cord injury, multiple sclerosis is one of the common disease, developing disease in women. Guillain-Barré syndrome, not very uncommon, myasthenia gravis, and some form of muscular dystrophy or inflammatory myopathy. If history is there, then always you have to take consideration, especially to take care of the muscle weakness. Next slide. Regarding investigations, other than the normal investigations, one is arterial blood gas analysis, next one is radiography, and third one is ECG. So these are the three tests other than normal routine blood tests we do. It's not possible to go in details of ABG analysis. In the few rule of thumb formula is if pH is low, that is acidosis, pH is high, this is alkalosis. If pH is low, bicarbonate low, that is metabolic acidosis. pH high, bicarbonate high, metabolic alkalosis. pH low, high bicarbonate, respiratory acidosis. pH high, low bicarbonate, respiratory alkalosis. And there will be compensatory mechanism in response to pH. Basal pressure of carbon dioxide may go low or high in presence of acidosis. In metabolic acidosis, it will go low. In metabolic alkalosis, it will go high. In case of respiratory acidosis, CO2 will go high. In respiratory alkalosis, CO2 will be low. This is in the simple metabolic acidosis or respiratory acidosis. And many of the time, we have combination of metabolic acidosis with respiratory alkalosis, metabolic alkalosis with respiratory acidosis. In those four group of disease, that calculation is different. Can you go back to the previous slide? Can you go back to the previous slide? Yeah. So regarding radiological investigations, there is no evidence that radiation exposure to the diagnostic range. You have to specify that one. If you are using just one, maybe one STI, or using less than 10 rads, it will not have any major side effect. But if you are using repeated, you are exposing the pregnant lady for repeated X-rays, then it can lead to congenital malformation, stillbirth, miscarriage, growth retardation, and so on. So normally we try to avoid X-ray exposure as much as possible. Regarding electrocardiography, it's easy, non-invasive, without risk to the unborn fetus, but it's not at all, not very specific. It's not at all specific because in many conditions you may get some sort of STs and Js, some sort of inverted UAF that many of the time is normal in pregnant lady. So although we do ECG normally in all patients, but that interpretations have to be taken with caution. Next slide. Next slide. Yeah, next. So oxygen therapy is the cornerstone. I'll go a little fast. I think already I'm going ahead of time. So is the has to be utilized before even like patient comes to the emergency and you're going for investigation. By that time you can start oxygen therapy, and then definitely if there is clinical deteriorations, there is improvement with early initiation of oxygen therapy. Next slide. Okay, so this is important. Different system or how to go for oxygen therapy. So it based on how much oxygen you want to give to the patients. Like if you want to give very low flow oxygens, you can go with the nasal cannula. With nasal cannula, you can go up to 5 liters of oxygen per minute. It's very convenient. Patient can talk, even talk and eat while receiving oxygen. But if you want to give more oxygens, like patient require more than 5 liters of oxygen, you should not use nasal cannula. Only problem is easily dislodged, not effective if patient is mouth breather, and if there is some local problem like patient is having deviated nasal septum or polypsitis, then can not be possible. Simple fast mask, if patient require oxygen therapy more than 5 liters, we give normally in the ward with the facial mask. So it's otherwise effective. It's easy. The only disadvantage is patient feels suffocations and patient has have difficulty taking food, and during eating and talking, during eating time he has to remove his facial mask. Otherwise, it's for high flow oxygen is one of the simple oxygen delivery system. Next slide. Yeah, so this is a simple example of nasal cannula and facial mask. Go for the next slide. Non-repeater masks, we are having now experience of using repeater masks, especially in ICU settings. We do not use normally do not use this repeater masks in the ward. Advantage is with a good fit, you can deliver almost up to 10 to 12 liters of oxygen. Like in COVID patients, normally some of the patients, they require 12 to 13 liters of oxygen. In those patients, you can use this non-repeater masks. We do not use in the normal ward because of the risk of suffocations, the chance of hyperoxygenation is there. I'll come to that later, and their possible lack of immunity. The masks definitely interfere with talking and eating. Next slide, please. And this is the example of non-repeater masks. Next slide. So partial repeater masks, the only advantage is that it has no one-way valve, so there is no valve in between, so that expired air mixed with the inhaled air. Otherwise, their functions are almost same. They can deliver 10 to 12 liters of oxygen with concentration of 80 to 90%. Next slide. So this is the repeater mask. So it's quite effective. We are using in almost routinely nowadays in COVID patients. First, I don't have personal experience. This one, it covers mostly the nose and mouth, but does not create the seal around the nose. I'll show the diagram and I'll have some idea. Go for the next slide. Again, this one you can give very high flow oxygens, like it will not obstruct the nostril, but it covers the mostly this areas. I don't have personal experience of this. Sensory mask is again normally used in ICU settings. You can give very high flow oxygen. There are different color systems right here, and based on different color, you can deliver different flow of oxygen. It can go up to 6, 8, 9, 10, 12, 14 liters of oxygen. Next slide. So this is the sensory mask. I think Dr. Bijoy will give one better concept or better idea regarding use of sensory mask and this high frequency oxygen flow mask. Next slide. Regarding oxygen therapy, one has to be take caution regarding oxygen toxicity. First one is especially patients with chronic hypoxia, those with COPD, and normally their inspiratory center is stimulated by the low hypoxemic state. Normally in normal persons, in our like in for ourselves, normally our inspiratory centers is stimulated with slight hypercapnic state, but in case of chronically hypoxemic patients, their respiratory drive is maintained a little bit up in the hypoxemic state. So if you give oxygen and if you remove that hypoxemic drive, that you may ultimately it can have deleterious effects to the patient. So you have to be very careful giving oxygen therapy, especially with chronic hypoxemic patients. There are two types of oxygen toxicity can happen. One is CNS effect and one is pulmonary effect. And this normally happens when we give hyperbaric oxygen for some other reasons, and we are giving high flow oxygens for prolonged durations, like we are giving very high flow oxygen for more than 12 hours. In the acute event, mostly it affects the central nervous systems. It causes BART effect. It was described by BART. And normally there will be twitching movement in the small muscles of hands, and there will be twitching muscles of the perioral muscles acutely, and then followed by acute confusional state leading to, and later maybe hyperconvulsive disorder or seizure disorders. In the pulmonary effect, mostly found in if you are giving high dose of oxygen for prolonged period, then it can cause lung damage. So CNS effect is mostly acute event, and pulmonary effect is mostly the chronic event. It characterized by trachobronchitis. It may lead to ARDS. It may lead to pulmonary fibrosis. In case of preterm newborn, as we know that it can cause retinopathy of the prematurity or retrolental fibroplasia. This oxygen toxicity, one note that it should used more cautiously in patients who have herbicide poisonings and patients receiving one chemotherapy drug, that is bleomycin, that can have more chance of oxygen toxicity. Next slide, please. So few indications for medical ICU admission in case of severe dyspnea that respond inadequately to initial emergency treatment, changes in mental status like confusion, lethargy, coma, persistent or worsening hypoxemia, partial pressure of oxygen less than 40 millimeter of mercury, or severe respiratory disease, need for mechanical ventilations, or patient is having hemodynamic instability like need for pressure or inotrope supports. Next slide. And one patient is shifted to ICU, then most of the patients they require invasive mechanical ventilation, especially those with ARDS. Indications are if patients cannot tolerate NIV or NIV failure, status of post-respiratory or post-cardiac arrest, acute confusional state, agitated, not controlled with sedative. You cannot give NIV for those patients. For NIV, you need patient cooperation very much. Severe respiration or vomiting, severe hemodynamic instability, not responding to fluid resuscitation or even vasopressor support, and ventricular arrhythmia. For those, we have to go for invasive mechanical ventilations. These are the future perspective which can be taken up by the young researchers, like role of antioxidant drugs for prevention of fetal hypoxia, like melatonin, vitamin C, resveratrol, erythropoietin, and these are the second one is the recent highlighted topic microbiota. Macrobiota, it's like called all the flora of the GI, and try to find out link between the GI system with different systems like nervous system, respiratory system. You can find the link of environmental risk factors or epigenetics from the microbiota, and detection of oxidative stress markers. And that is one of the area which we can take up for to study the effect of hypoxic conditions and to find out the new targets and possibly the treatment options, different treatment options. With this, I thank the organizers for again giving me the opportunity to be part of this program, and thanks for the audience for patiently hearing. Thank you.
Thank you so much, sir. Thank you so much. So, whoever is having any queries related to this topic, please write down in chat box. Like yesterday, we will discuss at the end of the session. So, Now, I would like to request our next presenter, Dr. Vijay sir. Sir is Assistant Professor in Tuberculosis and Respiratory Disease and also a Nodal Officer in COVID-19. So, sir is dealing a topic on COVID-19 therapeutic management. Uh, yes, decline. Hello, Dr. Noel,
Hello,
sir?
can you hear me?
Yes, sir.
Nanuka, I'll share my screen if
Yes,
it's okay.
sir. Yes, sir. Yes, sir. Yes, sir. It's visible.
Is it
Yes.
go to slideshow?
Yes, perfect.
Is visible? Is it visible?
Yes, sir. Perfectly visible, sir.
Okay. So I, at the outset, like to give my thanks to the team at RISE for organizing this webinar. So the topic that has been given to me is the therapeutic management of COVID-19. So we had just listened to a very interesting and insightful talk from Bhupen sir on hypoxemia and management of hypoxemia. So in today's talk, it will be a very short presentation. The objectives for today's talk will be to review the severity of COVID-19 with respect to pregnancy. Is there any difference between pregnant and non-pregnant disease? To discuss the different treatment modalities for COVID-19, and I'll also be giving a brief overview of the important drugs that are being used in the treatment of COVID-19 and with respect to pregnancy, where they can be used and cannot be used. Going straight ahead, uh, this is important to know that pregnant women do not appear to be more likely to contract the infection than the general population, than the general non-pregnant population. However, we must understand that in pregnancy, there's an obvious physiological alteration of the body's immune system, which may influence the way the pregnant person reacts to infections in general and COVID-19 in particular. And furthermore, there's now new evidence, emerging evidence to suggest that vertical transmission is probable. And this is especially important when we are handling COVID-19 in late pregnancy or COVID-19 near labor, where at that time we have to always remember that we are dealing with two lives and not one. And there's no current data to suggest an increased risk of early miscarriage or early pregnancy loss with relation to COVID-19. And there's no evidence currently to suggest that the virus is teratogenic. But of course, this is all, we don't have any long-term data. COVID-19 itself is just roughly 1.5 years old. So any data that we have is really limited to that. So we don't have any long-term data. And in the majority of the major clinical trials, early on in COVID-19, they have excluded pregnant women. So that is why there's a lot of data with regards to pregnancy in COVID-19, which is missing because most of the major trials have excluded, in early trials of COVID-19 have excluded pregnant women. And COVID-19 infection is currently not an indication to undergo medical termination of pregnancy. So knowing that, the next thing, we should also understand, probably we did not have much of in pregnant people involved getting COVID-19 in the first wave, but definitely we have seen an increase in the number of pregnant women getting infected with COVID in the second wave. And I don't know how many of us here have remember the last major pandemic that we had, that of H1N1, which is roughly just over a decade ago. And H1N1 was notorious in having a very high fatality among young pregnant women. And it was really sad, especially my own personal experiences when I was in Chandigarh, where we lost a lot of pregnant women because the disease had an unusually high fatality among pregnant women. And a similar scenario was emerging in the West, actually, where during the second wave, they found that pregnant women had significantly higher rates of ICU admissions compared to non-pregnant women, that too adjusted for age, ethnicity, and underlying medical conditions. And pregnant women were at a higher risk of any instance of preterm birth and stillbirth. And there was the main risk factors for them were an increased maternal age, a higher BMI, comorbid conditions, and the presence of preeclampsia in pregnancy. So we know that, so what we are seeing now is that even though they share the same risk factors as non-pregnant women, there is no higher risk among pregnant women in contracting COVID, but we must be alert because newer data is showing that once a pregnant lady gets COVID-19, it may progress into a more severe disease than someone who is non-pregnant. So, is there any difference of COVID-19 in a woman who is pregnant and non-pregnant? So, this is the latest guideline that was developed by AIMS, and this is of course being followed by the ICMR also. And how they classify the disease again is based on respiratory rate and oxygen saturation into mild, moderate, and severe. If we look at mild disease, there's just upper respiratory in symptoms without any shortness of breath or documented hypoxia. Moderate disease has any one of a respiratory rate of more than 24, that is mild tachypnea, and an SpO2 of around 93% on room air. Whereas severe disease has any one of a respiratory rate of more than 30 per minute with a saturation of less than 90% in room air. However, for pregnant women, the Society for Maternal and Fetal Medicine in the United States has suggested that for severe disease, we have to have a lower threshold for hypoxemia, that is a cutoff of 94%. A cutoff of 94%, saturation of less than 94% in room air in pregnancy is to be classified as a severe disease and not as a moderate disease as it is for a non-pregnant woman. So that tells us that yes, we should be more alert when we are handling pregnant women. Be more alert with regards to the oxygen status of these patients, especially if we are monitoring them at home. So coming to the management of COVID-19 in pregnancy, most important thing is that the therapeutic management of pregnant patients with COVID-19 should be the same as that for non-pregnant patients. However, management of COVID-19 in pregnant patients should also include fetal and uterine contraction monitoring based on gestational age whenever it's appropriate, because we should remember that here this is a very unique scenario where we are dealing with two lives and not one. But at the same time, in the same breath, we have to take into consideration, especially if it is early in pregnancy, that the life of the mother is more important than the fetus, especially if we're talking of early pregnancy or mid-trimester. And there should always be an individualized delivery planning. So all this basically can be summarized into this simple fact that management of pregnant women with COVID-19 must always involve a multidisciplinary approach. And the multidisciplinary team should always include an obstetrician, specialist in maternal fetal medicine, infectious disease specialists, critical care and pulmonologists, and also pediatricians. So it is always in an ideal scenario we would have all of them, but in real scenarios, it is always better we should always have a consultation. If it's not possible to have it under one roof, then at least we should have regular consultation and discuss patients between all these various specialities, especially when we are dealing with pregnant women with COVID-19. And that way we can always optimize and tailor-made the intervention and the treatment based on their individual presentations. So for asymptomatic or mild COVID-19 pregnant women without any comorbidities, not in any obstetric emergency or not in labor, the ideal treatment modality would be to isolate at home. Teleconsultation if feasible. We have teleconsultation services here in Negrams, and also in Meghalaya, not only in our state. We not only have teleconsultation, but we also have home visit teams, where there are teams of doctors and nurses who go and visit COVID-19 patients in their homes for monitoring them. So we can optimize, we can optimize these services, especially for pregnant women, so that they can be monitored more closely at home, and fetal monitoring after 2 weeks for growth, for fetal growth, and Doppler for the fetus. At home, of course, they can always keep a monitoring chart. A sample is here. A sample of a monitoring chart would be here. Basically, where they record the temperature, their pulse rate from the pulse oximeter, the SpO2 from the pulse oximeter, and a general symptomatology, whether they're feeling the same, whether it's feeling better, whether they're feeling worse compared to, say, the previous hour or the previous day, and also another symptomatology with respect to their breathing. And all these would give the home visit teams or the teams in teleconsultation a fair idea of how is the patient, and if they have and especially if they can give values of the SpO2, that will give us an even a clearer picture of how the patient is at home, and if there's any indication to immediately transfer the patient to a hospital. Treatment at home, most important thing is adequate hydration. Symptomatic management such as paracetamol, SOS if there's any fever or myalgia or headache. They should continue the regular medications that they're taking through their pregnancy, such as folic acid tablets, their iron tablets, etc. And tetanus vaccination should not be withheld because of COVID-19 if it is due. They can continue go ahead with tetanus vaccination as part of their for their pregnancy, even in the presence of COVID-19. So certain other important signs and symptoms which should alert the clinician, especially the home visit doctors or the doctors on teleconsultation. Symptoms include worsening of shortness of breath. There's an inability to tolerate oral hydration or the medications. There's persistent pleuritic chest pain. There's new onset confusion or lethargy. There are obstetric complaints at the patient, such as preterm contractions, vaginal bleeding, or decreased fetal movement. And important signs to note include tachypnea. There's persistent fever, which is unremitting despite paracetamol. Then the oxygen saturation falls below 94, 95%, either at rest or on exertion. And there's evidence of cyanosis, whether it's central or peripheral cyanosis. These are all indications that these patients need to be shifted to the hospital for better management, for better management. So coming to the management of COVID-19, the drugs for patients who are admitted, we have a whole lot of drugs here. But what makes my job easy is that there is no drug of choice. Remember that for COVID-19, we don't have a drug of choice. There's no gold standard of treatment approach. The ideal way is always to individualize the treatment of such patients. And so going further ahead, this is probably the most important line, and these are guidelines which are taken from the American College of Obstetricians and Gynecologists, and also from the Royal College of Obstetrics and Gynecology. And they have clearly defined that potentially effective treatments for COVID-19 should not be withheld from pregnant women because of theoretical concerns related to the safety of using those drugs, using these agents in pregnancy. So what are the treatment options that we have? Oxygen, like Dr. Bhupan had clearly mentioned, oxygen should be titrated to target the saturations of 94 to 98%. Then IV fluid management, there should be cautious use of management, because especially near labor, because these patients may tend to go into fluid overload, and especially if they're already hypoxemic, fluid overload may worsen hypoxemia. Antibiotics if there is a clinical suspicion of any bacterial infection or sepsis. And one important aspect is the use of radiological investigations such as a chest X-ray or a CT scan. Now, if there is a definite clinical indication to do a chest X-ray or a CT scan to rule out any other underlying any other cause for hypoxemia or pneumonia, then they can go ahead. The Kingdom guidelines on imaging and radiation in pregnancy recommends that a maximum exposure of up to 50 milligauss is acceptable, and a single exposure to a chest X-ray or a CT scan is well within that permissible limit. So if there is a need to do a chest X-ray or a CT scan, one should not withhold this investigation just for the fact that the lady is pregnant. We always have lead shields, which can be used both in chest X-ray and on C and in CT scan, which are always present in most radiological departments. Now, another important aspect is management of venous thromboembolism. This is because pregnancy per se is a high risk state, is a hypercoagulable state. It is a high risk state for venous thromboembolism, and also COVID-19 per se, the risk of venous thromboembolism is high. The disease process itself puts one at a very high risk of developing venous thromboembolism. So all pregnant women should be assessed for the risk of VTE and should be prescribed with thromboprophylaxis with low molecular weight heparin unless there's a contraindication. So contraindications for low molecular weight heparin includes renal failure. And then the doses of low molecular weight heparin should be individualized based on the patient's weight. Now, another important drug which is used in COVID-19 and also in pregnancy is the use of steroids. Dr. Bhupen had already spoken about the use of steroids. Now, corticosteroid therapy should be used when we're talking of steroid therapy for the management of COVID-19. They should be used for at least 10 days or up to the time of discharge, whichever is sooner. Preferred steroids include oral or IV prednisolone or methylprednisolone and IV hydrocortisone, because these drugs do not usually cross the placental barrier. However, if steroids are needed for fetal lung maturity, that means if a person develops COVID in late third trimester, near term, or in late preterm or early preterm, then in that case we may need to give steroids for fetal lung maturity. In such cases, then you can give intramuscular dexamethasone at 6 milligrams every 6 hours, every 12 hours for 4 doses. Now, among steroids, yes, most of the guidelines have also considered dexamethasone for use in COVID. However, recent studies have shown that methylprednisolone, IV methylprednisolone at low dose have definitely shown to have a better survival benefit than IV dexamethasone. And even here, even from there are certain unpublished studies, but unpublished data, even from East Coast also, we've shown that patients on methylprednisolone have shown a better survival benefit over those on IV dexamethasone. And even in our hospital also, if there is a preference of methylprednisolone, mainly because of the fact that methylprednisolone has a better lung penetration compared to the other systemic steroids. Now, coming to the other important drugs. First of which is remdesivir. Everybody is talking about remdesivir. Remdesivir is a nucleotide analog, and unless the clinicians believe that there is a strong, should be avoided. And if used, it is to be used only if there are clear-cut indications, such as early in the disease, there is moderate to severe hypoxemia with or without radiological changes, and the patient is not mechanically ventilated. And the risk profile, the fetal risk profile in remdesivir with regards to COVID-19 is largely unknown. We don't have any studies. However, remdesivir, if we all know, has been used previously in during the epidemics of the Ebola and the Marburg viruses. And in using the data from that, the data on the use of pregnant people, use of remdesivir in pregnant people during those epidemics have shown that there were no reports of any fetal toxicity with remdesivir. However, any decision to treat with remdesivir should be taken by the multidisciplinary team, which includes your obstetrician and your infectious disease specialists. And if remdesivir is to be given, and if there are no contraindications to the use of remdesivir, then they use the standard regimen of 200 milligram loading followed by 100 milligram once a day for 5 days. This can be prescribed. Another drug which is very much in vogue right now is tocilizumab. Tocilizumab is an interleukin-6 inhibitor, and there is no currently there's no compelling evidence that tocilizumab is either teratogenic or fetotoxic. However, tocilizumab, there are certain specific indications, that is severe hypoxemia, saturation below 92% on room air, or requiring high oxygen therapy. And there's evidence of systemic inflammation, such as elevated C-reactive protein, elevated levels of interleukin-6. And again, when using tocilizumab, always it should be the decision of the multidisciplinary team. And if there is an indication to use tocilizumab, the dose of tocilizumab is around 8 milligrams per kg. Give it as a single dose. And if there is improvement and well and good, if there's no improvement, you may increase to a maximum of 3 doses every 8 hours apart. Now, two other drugs which are used in non-pregnant in the non-pregnant population, but there's really no strong safety record in pregnancy, and these include ivermectin and baricitinib. Now, ivermectin, as we all know, is an antiparasitic, has been used effectively in COVID-19, though most of the major studies and especially in the West have not shown any major clinical benefit. But of course, there's no evidence of any serious harm also with the use of ivermectin. But with regards to pregnancy, again, its safety in pregnancy also is not really that well known. And baricitinib is an oral drug. It's a JAK kinase inhibitor, is a JAK pathway inhibitor. And usually if baricitinib is to be used, it should be used in conjunction with remdesivir and should never be prescribed alone. However, again, in pregnancy, there's no data on the use of baricitinib in pregnancy. So definitely if we were to use in pregnancy, it should be used with some caution, and the patient has to be explained that we don't have much data on its safety profile in pregnancy, whether to the mother or to the fetus. Now, other drugs which are otherwise safe in pregnancy, hydroxychloroquine, lopinavir, ritonavir combinations, azithromycin, they have all been shown to be ineffective for COVID-19, and these are more or less avoided. So even though these drugs are safe to be used in pregnancy, hydroxychloroquine has been used in multiple number of cases of rheumatoid arthritis, systemic lupus erythematosus, those even during and carried through during pregnancy. This drug is proven to be safe in pregnancy. Lopinavir and ritonavir are also used for those patients with patients of HIV with pregnancy, and these drugs have all proven themselves to be safe in pregnancy. However, the efficacy in COVID-19 has most of the major studies have shown that there have been no clinical benefit with these drugs. So it's better that we avoid these drugs in pregnancy, as they have no major clinical benefit. So another therapeutic option that we have, but a non-pharmacological option that we have, is the concept of awake proning. Awake proning is also feasible in pregnant women, and as well as those in early postpartum patients. And padding and support devices such as pillows or padding from the operating rooms may need to be utilized. And awake proning is indicated for those who are not intubated, and the patient, especially the antenatal pregnant patients, they need not go to, and especially those in late pregnancy, need not go to a full prone position. They can even stay in a lateral decubitous position without any problems. And for those in early pregnancy, they can go into a full prone intubation. So awake proning, along with oxygen therapy, has been shown to be very useful in mitigating the use of intubation in patients with hypoxemia and COVID-19. So how do we go about performing an awake proning? Here we can see that the patient is in a lateral decubitous position with supportive pillows and pillows in between the knees. And if you can even further turn them around, especially those in early pregnancy, with adequate proper support over the legs, in the pelvis, and also over the chest and neck, while providing room over the abdomen, so that there will not be undue pressure over the abdomen and the gravid uterus. So indications for intubation and ICU care, of course, if awake proning and all the other therapeutic options, despite all these, if there's no major improvement, then yes, the patient may need to be intubated and managed in the ICU. Few indications include the inability to maintain SpO2 above 95% with supplemental oxygen. There's presence of hypertension despite fluid resuscitation. Your mean arterial pressure is less than 65 millimeters of mercury, and there's evidence of any organ dysfunction. Either there is renal dysfunction, hepatic dysfunction, altered mental status, and all that, they are all form indications for intubation and mechanical ventilation. And of course, management in the ICU is another totally different topic altogether, and I will not elaborate that here in this talk. So to summarize, pregnant women should follow all the same recommendations as non-pregnant persons in avoiding exposure to COVID-19 infection. We have to understand that their risk in contracting the disease is the same as a non-pregnant population. However, once they get the disease, it is always important that to remember that they have a higher risk of developing severe disease. Hence, their monitoring and their follow-up is extremely important once they get COVID-19. And antenatal care through teleconferencing or video conferencing is key to providing quality care during this pandemic. And most importantly, a multidisciplinary approach to the management of suspected or confirmed COVID cases is the key in managing COVID-19 in the pregnant woman. So with that, I would like to conclude my talk. Thank you very much for your patient listening.
Thank you. Thank you so much, sir. Thank you so much for the amazing session. So I will request our presenter to stay back so that we can take up the questions at the end of the session, sir. Thank you, Vijay, sir. So now I would like to request our next presenter, Dr. Rosina ma'am. Ma'am is an assistant professor in Department of Pediatrics. So ma'am will be presenting on management of neonatal health, recommendations of essential newborn care of small baby and danger sign. Over to you. Yes, ma'am. Yes, your screen is visible, ma'am.
Okay, can you see my slide now?
Yes, ma'am, perfectly.
Okay.
Over to you, ma'am.
Thank you. Thank you once again, Nanuka and Japaigo Rice, for giving me this opportunity to speak on this topic on neonatal health. I know we did a 1-month program intended like only for pediatrics. I'm really thankful that I got this opportunity to talk more about newborn health. Hold on, let me just minimize this hide floating. Okay. And so today I've been given this topic on management of neonatal health. So what I will be talking about today is recommendations of the early newborn care of small babies, danger signs, and neonatal resuscitation algorithm. So basically, what I'll be telling you is something that most of you will be familiar with. I have sent a pre-test today, and those will be all taken up in today's talk. How do I remove these thing on top? None optimize.
Ma'am.
Hide video panel. No, not this one. Okay, now I'm trying to remove this. All right. No, that's fine. That's okay. So basically, what I'll be covering today is will be applicable to both newborn babies who are either born to COVID positive mother or to a mother who is healthy or not infected with COVID-19 pandemic. So these recommendations, these care will not differ irrespective of the COVID-19 status of the mother. Now, can we start with the poll, Nanuka? We'll do one after another. Okay, so I would like to ask all of you if you are, before we start any further, I just want to see a baseline if we all know, okay, that's a good response. Are you aware of essential? So the first poll is, are you aware of essential newborn care? So we have about 1,000 participants. Around maybe 300 have participated.
Yes, ma'am.
Maybe more will participate. That will give us a better idea about the rest of our participants. Even if you say no, nothing is going to happen. That's why you're here to learn, isn't it? Okay. So, and the second question is, have you done any basic neonatal resuscitation course? So we had about almost 500 participation. We are okay on time, aren't we, Nanuka?
Yes, ma'am. Yes, ma'am. We are okay with time.
We have over 500 participants. Should we continue or should we? Okay,
Should I
some more.
end the call, ma'am? It's 5:50.
Okay, so we can end it. Yes, yes. I think we can end it. We can share the results. As you can see, around 83% of the participant here. I'm very happy and glad to know that almost 83% are aware of essential newborn care, and about only 44% have done. 44, that is out of the 563 that have answered this poll, only 44%. That means less than 50% have done any basic neonatal resuscitation course. Is there another poll or is this it?
This one is the only one.
This is
We
it,
have
isn't
only
it?
one. Yes, ma'am.
Okay, all right, okay, fine. I don't know, there was a question that if you have worked in delivery rooms, anything, maybe that will give us a better idea of our participants' profile. Anyway, I think I forgot to put that. So yeah, so we can end this poll.
Yes, ma'am. I have ended.
All right, okay, thank you. So I think I don't know where that question is, but it would be a good idea if you can just put in the chat box how many of you are working in delivery room or in in the labor room or delivery room. Maybe that will give us a better idea about this 44% here. That is quite discouraging to see. Okay, so maybe most of you are not working in delivery room, which is fair enough. I think a poll. So let's go with to our next session. So why do we need to know essential newborn care? Isn't it? You must be thinking it's the same thing over and over again. What are we missing? Why do we need to do this? Okay, so if you look at this, this is a study published by the Lancet 2019, June 2019. So this is the causes of under 5 mortality. This is for India. Under 5 mortality deaths. And if you look at this, a huge proportion, more than 50%, almost 58% is because of neonatal deaths. That's a huge chunk. More than 50% of these deaths are because of neonatal deaths. All right, and if you can see, most of them are preventable. Okay, most of them can be done. So this is when your essential newborn care comes into play. You do all these steps, you follow all the essential newborn care steps and interventions, you will be able to cut down this by half, this neonatal deaths by half. All right, let's see what happens. Let's see let's see about the other deaths. So if you look at the infant mortality rate, that is the probability of an infant under 1 year per 1,000 live births dying. So if you look at it, the number is 28 per 1,000. For neonatal mortality, this is as per the 2019 data in India, it is 21. So as you can see, 21 out of 28 is a neonatal death. So if we can work on this, that is the lowest hanging fruit, isn't it? We can drastically lower our infant mortality rate. Similarly, if you look at the under 5 mortality rate, we have 34 under 5 deaths per 1,000 live births. Again, more than half of it is neonatal, as we've seen just now. It is neonatal cause. So if we can tackle this lowest hanging fruit, then we can significantly reduce our infant mortality rate and under 5 mortality rate. All right, and it's not difficult. It's not difficult. Okay, we have very set events and set interventions to do. If we all follow this, most of us we can help in reducing our neonatal mortality. If you look at the trend in India, it is obviously going down, but not down enough, not low enough. Okay, if you compare this number, the infant mortality number, with the rest of our neighboring state, barring Pakistan, we are still higher than most of them. Okay, we're higher than Bangladesh and Sri Lanka. It's still high. All right. So this number is not good. We need to lower this down, and the best way to do it significantly is by reducing the neonatal mortality rate. Let's look at Meghalaya. Even in Meghalaya, the trend is reducing. This is for India. Okay, since 2003, and this is for Meghalaya. The trend is also reducing, but it's still higher than the national rate. All right, the number is still high. We need to work on this. If you compare Meghalaya with the rest of the northeastern country, this is for the urban mortality, infant mortality in urban areas. It is still very high, 24 in Meghalaya, 21 in Mizoram, 17 in Nagaland, 23 in Tripura, 23 in Assam. Meghalaya is still very high. All right, so the picture is what this literally means. What I want you all to know is we still have a lot to do. We haven't reached there yet. Our healthcare essential newborn program is not, we have not reached our targets yet. There's still a lot to do. So what is the definitions of essential newborn care? So this is basic care of newborn to ensure survival and well-being from birth up to 28 days. Now remember, the newborn is counted as a newborn until he finishes 28 days. So within the first 28 days of life, that's a newborn. So basic care, we're not talking about any hi-fi care, any cost, what do you call, we're talking about very cost-effective care of a newborn to ensure survival. All right, this is essential newborn care. I hope this is clear for everyone. Okay, basic care, basic care. The essential newborn care intervention. So with essential newborn care, we have what is known as intervention. So with essential newborn care intervention, these are a series of time-bound and chronologically ordered care. So look at these words carefully. These are time-bound. Okay, if you have to do it at that particular time. If you miss that window, you are adding up to more neonatal deaths. All right, okay, or morbidity. So these interventions are a series of time-bound, chronologically ordered care. So chronologically, I think that's self-explanatory, that a baby receives at birth and it has a standardized, effective procedural or intervention steps. Okay, so those are the intervention steps, essential newborn intervention steps. Now, what are the components of essential newborn care? Why is it okay? So clean delivery practices and asepsis, this is the most important. I think all of us are aware of this. Care of the baby at birth, we'll talk about this in detail. Prevention and management of hypothermia, this is again a very, very important aspect of prevention of neonatal deaths and morbidity. Initiation of breastfeeding, I think all of us are aware of this. Again, I will reiterate this again. Care of the baby in the postnatal ward. So basically this and timing of discharges and what are danger signs. Okay, what I have not add here is a small, okay, we'll come to that anyway. So this is what we will talk about, essential newborn care. Okay, so from the time the baby is delivered until the baby leaves the hospital, it is our duty to make sure that we give essential, basic essential newborn care to this baby. Okay, so let's talk about the first one. So standard precautions and asepsis. Okay, so for just like we maintain standard precautions for any procedures, similarly for delivery, we have to maintain standard precautions and follow asepsis. So what we should do is we should treat all body fluids as potentially infectious, isn't it? Okay, wear appropriate PPEs. When you're attending resuscitation, you should wear gloves, you should wear mask and a gown. All right. If you're in a COVID area, again, wear appropriate PPEs. I think that you're already aware of that. And then another 5 cleans or 5 C's as they are called. All of us know this. Let's go to this one by one. All right. So the 5 C's are very, very important for maintaining asepsis in a delivery room. So what are these 5 C's or 5 cleans? So clean hands, clean surface, clean cut, clean thread, and clean cord. If you look at this, the last 3 are exclusively to the cord. Okay, this is very, very important. Okay, clean hands, like I said, maintain asepsis, so appropriate hand hygiene, wash your hands properly. Even after washing your hands, you need to wear sterile gloves, all right, before attending a delivery. You should use a clean surface. So use clean and sterile towel to dry and cover the baby. The surface where you're receiving the baby and where you're going to keep the baby has to be clean and dry. Then clean cut. This is for cutting the umbilical cord. All right. And this is a clean surface. This is for clean cut. So this is for cutting the umbilical cord. It should be cut with a clean, sterile blade or scissor, whatever is available, but it has to be sterile. Clean thread. We already have this sterile clamp that is available commercially. Okay. If not available, use a clean tie. All right. And clean cord. The cord should be maintained and it should be clean. Now, care of the baby at birth. So the first thing is you should prepare for the birth. All right. How should you prepare for birth? Whenever you're attending a delivery, You're always there before the baby is delivered, isn't it? You always see the doctor or the whoever a trained birth attendant is. They are usually there before the baby is born. So that's how it should be. Okay, whoever is taking care of the baby should be present before the baby is born, not after the baby is born. Okay, what should you do? First is check for the ambient air. Look at the room, whether it's free from any draft of air, whether there are any open windows, whether there are any fans that are switched on. All right, check the temperature of the room. It should be 25 to 28 degrees Celsius. And then when you reach there, after checking all this, you wash your hands. Okay, wash your hands. And then when you come there, you see whether how many trained personnel is required for the resuscitation. Is it one or is it two? How do you do that? You ask for the high risk questions. Okay, whether you can handle alone and you need somebody else. All right, and then before the baby is again born, you need to check for equipment. That is called resuscitation preparedness. So let's see. Okay, it's not moving.
I'm clicking the screen once again. Ma'am, you can click in the screen once again. I think because of that laser.
Okay, well, let me just remove the laser then.
Yes.
Okay. All right, so then this is a checklist for your resuscitation preparedness. All right, what does it mean? So if you go stepwise, these are all like chronologically things. If you look at stepwise at your steps of resuscitation, these are the things that you will need. So for providing warmth, you will need obviously a heater if you have, or switch on, bring up the room temperature to 25 degrees to 28 degrees. Okay, preheat the warmer. Remember the warmer, when you heat it, put it on manual mode. All right. Don't make it on a thing. Put it on manual mode. Switch it on for 20 minutes at least. Let it warm up and keep your towels there. At least 3 pre-warm towels has to be there for the babies. So warm them. If you have clothes caps, you can warm them as well. And check the room temperature. For maintaining thermoregulation, this is again like heated mattress and cap. You can put them under the warmer. Then you need plastic bags or plastic wraps. This is for extremely preterm babies, less than 1,000 grams. Okay, for positioning, if you need to position the baby, you should keep this shoulder roll, which is 2 centimeters thick, for clearing the airways. So you're going serially, you're going stepwise in your resuscitation. So similarly, you prepare your instruments in that way. So keep a suction catheter, 10 to 12 French gauge suction catheter, or a mucus sucker if you don't have a suction catheter with a wall suction or a portable suction. For ventilation, check for keep a self-inflating bag, check whether it's working or not. Check for the mask size, whether it's ask if the baby is a term or preterm baby, and keep the appropriate mask, and put a feeding tube and 20 ml syringe if you need to deflate the stomach. All right, or you need things. So, and then for oxygen delivery, keep the oxygen tubing on nearby, or if you have a T-piece resuscitator, keep that, pulse oximeter and oxygen blender if available. For intubation, if you have, keep laryngoscope with blades 0 and 1 and endotracheal tubes from size 2.5 to 3.5. So keep all of these ready. For medication, if you think you will need resuscitation, then keep this epinephrine 1:10,000 concentration and normal saline ready. Keep the supplies for umbilical vein catheter ready, and keep a neonatal case record sheet, because again you need to time what you have done at specific time, okay, for medication. And if you think this baby will require transport, then call ahead and ask for the transport incubator. All right. So this is your resuscitation, resuscitation preparedness. Then care of the baby after birth. What happened the moment after the baby is born until 1 hour after delivery? What will you do? Okay, so we have two things. One is providing routine care for all newborn, irrespective of their term or preterm baby. This is given to all newborn. And the second is you need to identify and manage newborn who will need special care. Okay, so whether they are special with a special newborn or not, you still have to give routine care, and after giving routine care, then you can manage them accordingly after this. So what is routine care? Okay, so what happened is, once you've prepared your resuscitation equipments, you washed your hands, you have prepared your all your equipments and all that, then what you do is you call at the time of birth. The moment the baby is born, call out. When I say call out, means call it loudly. Okay, call out the time of birth. Then once the baby is delivered, place the baby on the mother's abdomen and turn the head to one side. At the same time, you receive the baby with the pre-warm linen. All right, keep the baby dry, and you discard the wet linen. Then you clear the mouth and nose with a clean sheet. Now you assess the baby's breathing and drying. All right. So before this, when you're looking at the resuscitation algorithm, it'll tell you to see when you're calling at the time of birth, you're holding the baby, you have to assess again 3 things, whether the baby is term or preterm, look at the tone of the baby, whether it's good tone or poor tone, and then whether the baby is breathing or crying. So while you're assessing all that, you can do that on the mother's abdomen. All right. Then you assess whether the baby is breathing while drying or not. Okay. Let's first assume that yes, the baby is breathing. Now what will we do? You do a delayed cord clamping. Okay, so you clamp the cord and cut it after 1 minute. You wait at least 60 seconds. So you cut between 1 and 3 minutes. Again, you'll know this only if you are calling out the time of birth, isn't it? Or else you will miss it. Okay, so you practice delayed cord clamping at least 60 minutes. And when you clamp it, at least clamp 2 to 3 centimeters away from the abdomen. Don't let it hanging. Don't let a huge piece hanging away from the abdomen. Okay, very short, just 2 to 3 centimeters away from the abdomen, and then you can practice clean cut and tie, as we've said earlier. Then put an identity label for the baby. Okay, this should contain the name of the mother, the sex of the baby, the weight of the baby, and the hospital ID number. So that should be there in all identity labels of the baby. Then examine grossly for any malformations of birth injury. So any, like obviously encephalocele or any mass in the neck or any like CTV, any other like malformations. You can assess that and note it down. Or if there's any birth injury, you can examine that quickly. And then very important, initiate breastfeeding within 1 hour. Okay, so this has to be, you have to be very active and proactive in feeding within 1 hour. I know a lot of things happen, but assign somebody who can take care of breastfeeding within 1 hour. Okay, and this time should be noted and documented as well. We have done this in our labor room here in Nigrams, and let me tell you our rate. We've done this I think for almost 3 years now, and our breastfeeding within 1 hour in labor room is almost 85 to 90%. Why is it not 100%? Because some babies are preterm, some babies need resuscitation, some babies has birth asphyxia, so we will not be able to practice this. So they are immediately taken away to the NICU. Okay, so though that is normal. Okay, so 85 to 90%, again, it's a very good number. So you can also do this practice in your own setup. Then give injection vitamin K depending on the weight, record the baby's weight, cover the baby's head, and cover both the mother and baby with a warm cloth. Okay, so this is what routine care is about. Now what happens if the baby is not crying? So we kept the baby in the mother's lap. So you must remember that all baby, irrespective of whether they are term or preterm or whatever, they all need to be assessed for resuscitation. Okay, a personnel who is trained in resuscitation. It can be a doctor, it can be a junior resident, it can be a senior resident, it can be labor room staffs, it can be obstetrician, it can be anybody who is trained in resuscitation must be present, and they must assess whether the baby needs resuscitation or not. All right, so at least one person who is skilled in resuscitation must be present. And if you have to initiate ventilation, you must initiate it within 1 minute. That's why it's called the first golden minute. That's a short form of FGM. Okay, first golden minute. So let's come to this baby. Now you've kept the baby on the mother's cot. You've dried the baby. You've removed the wet linen. Now you're seeing whether the baby is crying or not. This baby is not crying. Okay, so what do? You don't wait for 60 seconds to clamp and cut the cord. All right, you immediately clamp and cut the cord. In this case, there's no delayed cord clamping. And then you take the baby and put the baby under the radiant warmer. Position the head with the neck slightly extended. You use your shoulder roll. You've kept that before ready. Okay. Clear the airway by suctioning the mouth and then the nose if required. Stimulate just 2 times rubbing the back. No point of stimulating the back and the feet and all that. Just once, either the back or the feet. Okay. And reposition. So basically you're clearing the airway. These are the initial steps. Now remember, this drying the baby, assessing the baby for breathing, initial steps, this should be done within 30 seconds. All right, it should not take you more than 30 seconds. Hence, looking at the time is very important. Then after you've done the initial steps, and then you see whether the baby is breathing or not. If the baby is breathing well, then you keep the baby for observational care. All right, I will talk to you about observational care. Then that baby is labeled as going for observational care. The baby is not breathing well. Like I said, you need to initiate ventilation within 1 minute. Okay, the first golden minute. So what you do, whoever is trained, Don't waste time calling the pediatrician. Don't waste time calling the anesthetist. Don't waste your time running out the labor room and looking for somebody. Whoever is trained, please initiate back and mask ventilation using room air. Again, do not waste time trying to fix the oxygen and the tubing. Okay, just use room air, use a back and mask, and then you start giving back and mask. Now, like I said, we have to give for 30 seconds. But before you go any further, what we are looking for is effective back and mask ventilation. What do I mean by that? It means that whatever you're giving has to be delivered to the baby. So how do you know that? So you give 5 breaths first. Yes, you do breathe 1, 2, and you look for chest rise. All right, okay. So once there's chest rise, then you continue this for 30 seconds. We're looking for effective chest rise. If there's no chest rise, you have to take corrective steps. Okay, so I'm not going to talk about the detail of neonatal resuscitation. We will be holding many of these later on. We will contact you when we have this. Okay, it's a whole day, it's actually a 2-day program, so it's not possible to cover this in the next 15 odd minutes or so. So I'm just telling you the brief things. For whoever is posted in the labor room, please do this. All right. Then if there's adequate chest rise, you continue for at least 30 seconds. Okay. Then again, you assess again whether the baby is breathing or not. All right. If the baby is breathing well, you go for observational care. Now, what is observational care? So observational care is basically placing the baby, again, once the baby is fine, after you've done initial back and mask for 30 seconds and baby is breathing. So what you do is you again put back the baby on the mother's breast. So don't keep the baby away from the mother, keep the baby back in the mother's breast. Cover the mother and the baby together, cover the baby with the cap, finish the rest of your routine care, okay? Like weighing the baby, giving vitamin K, all that. So you finish the rest of your routine care, then you initiate breastfeeding. Then what this baby is entitled to now is observational care. What is observational care? That means this baby in the next 2 hours is entitled to at least 6 observations or 6 monitoring. Okay, how will you do that? What will you monitor? You monitor for temperature, for heart rate, for breathing, and for color. So for the first hour, you monitor every 15 minutes. So you can make a chart or a format for any baby for observational care. They can use this, you can print it out and you can make your own, okay? So every 15 minutes, you can go and monitor this baby for temperature, heart rate, breathing, and color for the first 1 hour. And then for the next 1 hour, every 30 minutes. So that makes it a total of 6 observations, all right? So once you're sure that your all these vitals, all these indicators are normal, then this baby will be out of observational care. But obviously, if there's anything wrong with this, then this baby will need further evaluation. All right. Then other babies who will require observational care as well would be babies who are small in weight. Okay, so 1500 grams to 2000 grams, or baby requiring positive mask ventilation for less than 1 minute. So you've done initial back and mask ventilation for 30 minutes. Okay, the baby's heart rate is fine. You assess the breathing, the baby. This is basically what we just said just now. And the baby is vigorous. Okay, so this baby will go for observational care. If the baby requires more than this, we will come to that later. All right, I hope I'm clear and I'm not going very fast. Now, after you've done that, so suppose all of you, whoever's working the labor room, you know that not all babies are normal, isn't it? You have so many babies who need special care. So how do you identify who these babies are and what will you do with them? How will you manage them? All right. We're not telling you to work in NICU or to work in, to start doing intensive care, neonatal intensive care. No, we just need you to know how to identify this baby and what will you do with them. All right. So if you have any of these babies, so any low birth weight babies or preterm babies, so babies less than 2000 grams or babies less than 37 weeks. So these babies are special babies that will require special care. So they have to be sent to appropriate level, a level 2 or level 3 neonatal care. I'll come to this later. Okay, so just know that these babies, you cannot send them home, send them to the ward, send them to the mother. These will require some amount of observation and some amount of monitoring. Again, babies with major congenital malformation. Okay, this also will, again, you need to refer them with severe birth injury, suppose like a fractured clavicle or a dislocated shoulder, okay, or so many other birth injuries. So this will also need to be referred. A baby with birth asphyxia, baby with respiratory distress, or those requiring positive pressure ventilation or requiring back and mask for more than 1 minute. That means they need extensive resuscitation, or needing chest compressions or drugs. Obviously, okay, this will have to, even if they're crying normally, maintain saturation after all your intervention, they will still need to be referred for further monitoring and evaluation. Then let's come to the next part, that is the prevention and management of hypothermia in newborn. So let's look at this picture. I think everyone is very familiar with this picture, isn't it? Okay, this is the different ways of heat loss in a newborn. So imagine a newborn is born. All right, the newborn is born from is coming out from a temperature which is inside the mother's womb, okay, abdomen. The mother's temperature is what? Normal temperature, 36 degree, okay, and the outside temperature is how much? 23, 25 degree. So there's a sudden, the baby is going to come from a temperature that is very warm to an area that is sudden, like the cold temperature. If you keep the temperature of the labor room at 25, there's still almost 10-degree difference in the temperature, okay, and the baby is going to come out wet. So this baby has a high chance of developing hypothermia if you don't do any of these preventative or intervention steps. All right, now what are these preventive steps? If you know the ways that the baby is going to lose heat, you can prevent them. Okay, so let's look at the first one, convection. Okay, that is the temperature, like I said, outside is colder, 25 degrees, isn't, or maybe even lesser temperature, and the baby is coming up from temperature of 35 degrees. So to minimize this heat loss, what you do is you place a newborn away from direct AC vents, away from fans or open window, and maintain a draft-free room with a temperature of at least 25 to 28 degree. All right. So once you do that, you can minimize the heat loss by convection. Then evaporation. Okay, so this is insensible water loss from the baby skin. Okay, so how do you do this? You dry the baby immediately with a pre-warm linen, and then remember, remove this wet linen. Don't just keep it with the baby. Remove it, cover. We've warmed 3 linens, isn't it? So remove the first one, keep the second one. Okay, cover the baby, then cover the baby with dry, warm blankets. Then the third step, heat loss is by conduction. So this is, conduction means in contact with cold surface. Okay, so you warm the mattress. We've already said that in our initial resuscitation preparedness. You warm the mattress, you warm the blanket. Okay, even when you're measuring the weight of the baby, keep something warm below, like a warm paper or something below on the weighing machine to prevent conduction or heat loss. Keep the baby on the mother's abdomen. That's what we have said in routine care. So ideally, this is the best environment for the baby. Keep the baby on the mother's environment. The baby will automatically get contact with 36 degree temperature. And cover the surfaces. If you're keeping the baby on the bed or on a weighing machine, cover it with warm blankets or towel. All right. Then the fourth heat loss is by radiation. Okay, that is because of the surrounding cool objects. Okay, if you have like a glass window here or an open door here, okay, so their chance of heat loss by radiation is very high. So keep the newborn away from windows, doorways, and outside walls, and again keep the room warm. Okay, so once you know the different methods of heat loss in a baby, you can intervene. This is what is in essential newborn care intervention. Okay, so these are one of the steps you can do that. Then again, one more thing is maintain the warm chain. All right. So how do you maintain the warm chain? One is by keeping a warm delivery room, immediately drying the baby, having skin-to-skin contact at birth with the mother, initiation of breastfeeding. You can postpone your bathing and weighing. If it looks like a good sized baby, you can postpone it later. If it looks like a small baby or if it's a preterm baby and you need to act, you need to intervene based on the weight, then you can weigh the baby. All right. Put appropriate clothing for the baby. Rooming in is very important. Keep the baby rooming with the mother. If you have a transport, keep a warm transportation chain. If you have a transport incubator, even if you don't have a transport, even in intra-hospital transports, if you're transporting the baby from an OT or from the casualty to the NICU or SNCU, okay, you need to have this warm chain. You need to maintain this warm transportation. So either have a warm, transport incubator, or use other methods like kangaroo mother care. Okay, this is actually one of the best. All right, it's cost effective, it's cheap. You can use kangaroo mother care to transfer the baby as well. And let's come to breastfeeding. Okay, so this I hope everybody is practicing. So our aim is to initiate breastfeeding as soon as possible. Okay, the recommendation by the WHO and UNICEF is the baby should be breastfed within 1 hour of delivery. So what you do is, like I said, you've called out the time of birth, isn't it? You also have to note down the time of breastfeeding. So what we have done, I think if the sisters in labor room are here, are listening, they will know that what we have done is that from the time of birth, we also note down the time of the breastfeeding. So if suppose the baby is born at 11 a.m., okay, and the breastfeeding was done at 12:01 or 12:02 p.m., okay, that will still not be counted as less than 1 hour. Okay, so if you can see that, I think sisters and all will know that so many, to maintain this target of 1 hour, you see so many babies being fed at 11:55, 11:58 p.m. Okay, so anyway, that is good. At least they are proactive. That means what the message I want to send is breastfeed the baby as soon as possible and preferably within 1 hour. Then the health worker, obviously here, unless we have a trained birth attendant with us, the health worker will be not a trained health birth. In a health worker, if you have a companion, like a birth companion, they can also actively assist the mother in the breastfeeding. Breastfeeding ideally should be counseled antenatally, okay, for the mother. So if not, also at least you can tell her that time that you need to breastfeed. So you have an hour, okay, so tell her that you need to breastfeed within 1 hour. Very important to document the time of initiations of breastfeeding. And when you are doing that, when you're assisting the mother in breastfeeding, please ensure that there's proper attachment. All right, make sure the baby is attaching properly, look at the position of the baby, and make sure that the baby is suckling effectively. Then communication with the family, this is again very, very important. It's become a part of, like, not just with essential newborn care, but with everything, with medical practices right now. Okay, this is one of the soft skills that we all are lacking. We need to build up. So we need to communicate with the family. What do we need to communicate? I mean, we have like a birth companion, then this we can be done at the delivery room itself. Okay, so this should be communicated before they leave the labor room or the delivery places, and it should be communicated to the mother and the family. And very clearly, please state these facts. I mean, this might not be much of an issue here in Shillong, but again, in other places, it is very much an issue. So state clearly the gender of the baby. Okay, let's just say this is a baby boy. Okay, you have a baby boy whose weight is so and so, and tell the status. The baby is fine. It just needs to be breastfeed and all that advice. Okay, and then the baby will be shifted to the postnatal ward. Or if the baby is not well, you can say that the baby is he requires some positive pressure ventilation, so will be requiring some observational care. So somebody will come at this time to look at the baby. Or if the baby needs a referral to other center, you need to communicate that. Or if the baby needs to go to an NIC, you need to communicate that as well. All right, and then again, the gender of the baby must be identified during delivery, right? Must be identified by the mother or the family right after delivery. All right, that should be stated very clearly, and then you can communicate that further after they've identified it early on. Then once the baby is out from the delivery room, what will you do in the postnatal ward? Okay, so this baby is still in your charge, still needs your newborn care. All right, so again, similarly for the room, it still has to be free from any draft of air. The temperature of the room should be warm, above 25 degree. Rooming in is something that we all practice, so this should be together. The baby and the mother should be roomed in, irrespective of whether the mother is COVID positive or not. The mother and the baby are still kept together, maybe not in the same bed, but at the same room. Okay, the baby needs to be, the temperature of the baby needs to be monitored. Look at the breastfeeding, with the mother is able to breastfeed. Ask for any issues. If the mother has any issues, if she has any problems, any doubts, you can ask her. Then prelactal feeds. This is again very, very common. In so many cultures, they love to give prelactal feeds. Okay, they love to give honey. They love to give I don't know, milk or tea or rice water. This is not essential, not needed at all. Okay, in fact, just a few weeks ago in our own postnatal ward, we have somebody giving tea to the baby. All right, so this has to be, you have to be very vigilant. Have to be vigilant to see what the mother is giving and what is happening, what's going. You need to communicate. You need to talk to the mother and let her know if she's having any issues and what is she feeding the baby. Okay, and why is she having such issues. Okay, ask her why. So just keep on asking why. The answer will come out automatically. All right. And then monitor the passage of urine and stool, and then you can do a detailed examination of the baby. All right, we'll come to that later as well. Rooming in, like I said, it is recommended. This facilitates bonding and initiation of exclusive breastfeeding, early breastfeeding, and this is important. Like, you can start breastfeeding in the hospital. When you go home, how do you ensure that they maintain it? Okay, they follow the exclusive breastfeeding. So rooming in is one of the methods of ensuring that the mother can continue exclusive breastfeeding for next 6 months or so. All right, okay. If it's a COVID positive mother, again, we will still advise rooming in, which is following COVID appropriate protocols. Then examination of the baby. So initially at the resuscitation during delivery, you've just grossly seen the baby from head to toe, looking for any gross malformation. Okay, now you need to do a detailed examination of the baby. So this baby will need this. Okay, so this is being done like Half of these things are being done by our staff nurses in the postnatal ward. They're doing a very, very good job. Okay, most of these. So what they do is every day the baby, they check for the baby's temperature, the baby's weight, they see if the baby is lethargic, feeding well. For jaundice, okay, look at the level of jaundice, look at the abdomen, look at whether jaundice is up to the level of palms and soles or not. Look for any other malformation. Okay, so like cleft lip. Cleft lip will be apparent, obviously. So look for cleft palate, look for any facial dysmorphism, any spine abnormality, any anal malformation. Okay, so just look for all of these other malformation that you may have missed initially. Then you monitor for the rest of the vitals. So look for respiratory breaths, you count it for 1 minute, look for any signs of respiratory distress, look for chest retractions, look and listen for grunting. Then umbilicus, okay, look at the umbilicus, whether it is red, whether there's any pus around it, whether it's foul smelling. And then look at the skin, whether any pustules in the skin. If they're more than 10 or they're big, this needs to be treated, okay. Then also when you're examining the baby, if you're used to examining the baby, you will be seeing a lot of these normal phenomena, okay. So Epstein pearls, like a white sort of protruded thing at the midline of your heart palate, okay. So that's Epstein pearl, that is normal. Mongolian spots, very, very common. These are dark, almost bluish spots, bluish gray spots found at the back, very common in Asian babies. Capillary nevi, enlarged breasts, again very common finding. Nothing to do, please don't squeeze the breast, don't do anything, just leave it as it is, okay. Transitional stool might be talked as might look as diarrhea, but it's not. This is normal. Then in a female baby, you might hear or see complaints like vaginal discharge or bleeding, okay. Again, this is very this is a common finding, like normal phenomena in a female baby. Then on the second or third day of life, you see what is known as erythematum toxicum, red rashes on the skin. Okay, this is again very common. And again, measure the weight, like I said. So look, the weight loss should not be more than 8%, 8 to 10% in term babies, and not more than 10 to 12% in the preterm babies in the initial 3 to 4 days. So the weight loss is more than 10% in the term, more than 12% in preterm. You need to investigate this baby, and you need to note it down and intervene. All right, okay. So all of these things, again, like looking for all of these is a step for intervention. You prevent the baby from dying. Okay, so caring to the cord. I know, like out of the 5 C's that we've talked about, 3 of them are dedicated only to the cord, isn't it? Clean cut, clean tie, and care of the cord, clean cord care. Okay, so how do you ensure that the cord is clean? Do not apply anything on top of the cord. Do no ointment, no talcum, no local medicines. In some cultures, they have applied, I don't know, cow dung and all that. Please don't follow that. Okay, remember the cord. The cord is a vascular bundle. It's directly it's a direct vascular access to the baby. Okay, so anything that is septic there will infect the baby as well. Okay, so don't apply anything. Keep it as clean, as sterile as possible. Keep it dry and do not cover it. Okay, so that's how you should look for cover the cord, and inspect it once the baby is delivered. So basically it's a second examination when you're talking about like the examination of the baby. That should be done at least 2 to 4 hours later. That's when you should look for the cord as well. So what happens is you look for bleeding if the cord tie is loosened up, or if it is the cord has shrunken, your clamp has not been tight, as loosened. So those are very common things that happen. Okay, it's nobody's fault, it just happens. So again, that's important to examine the baby 2 to 4 hours later. All right. And when you're putting the nappy should be folded well below the cord stump to avoid contamination. Again, when you're cutting the cord, just cut it 2 to 3 centimeter away from the abdominal wall. Don't leave a huge stump, because again, this will eventually what, the tip will reach into the groin area and it will get contaminated. Okay, so your whole cord care is already like not being taken care of. Okay, out of your 5 C's, 3 are not been the last one is not been covered. So make sure that you cut the cord properly so that it's well above the groin area, so that you can keep it dry. Okay, so that's how you look for cord care. Then skin and eye, again, not much for skin and eye. You look for the skin. If you see more than 10 pustules, you need to intervene. A routine bathing is not advised for a baby. Maybe sponging with lukewarm water. Okay, dip bath, you do it only after the cord falls and the baby is discharged from the hospital. And as for the eye, except for the initial swabbing of the eye. So when the baby is born, you can clean the eye from inner canthus to outer canthus using 2 separate swabs. Other than that, daily routine cleaning is not required. Okay, even giving antibiotic prophylaxis is also not recommended. And these are the 10 steps to a successful breastfeeding. Every facility that has maternity services, that has delivery room, should abide by these 10 services, should be by these 10 points. I should be familiar with it. What I meant by that is these facilities should have a written breastfeeding policy that is communicated to all the healthcare staff working in the delivery or postnatal ward. All healthcare staff looking after the baby should be trained in skills necessary to implement this policy. All pregnant mothers should be informed about the benefits and management of breastfeeding and breastfeeding issues. The mother should be helped to initiate breastfeeding within 1 hour of birth. Show the mother how to breastfeed, how to maintain lactation if the baby is sick and separated and kept in an ICU. Give newborn infants no food or drink other than breast milk unless medically indicated. Practice rooming in, we've already talked about. Encourage breastfeeding on demand. Give no artificial teats, a pacifier, or dummies. And foster the establishment of breastfeeding support groups. So it may not be a formal group, but just a breastfeeding mother or your friends or your families who are all breastfeeding. You can establish a contact with them if you have any issues about breastfeeding, or you can always come to the hospital and address that as well. Okay, so once you discharge, you need the support. So especially the family members, the parents, the grandparents, or your friends or things. So just get that breastfeeding support group so that you can continue breastfeeding. Now let's come to the second part of my talk today, which is about small babies. So all of us, again, working in whatever center, have encountered small babies. Okay, I don't think we are familiar with small babies, but what does it mean? I made it very simple here. I've just classified into two. One is based on the weight and one is based on the gestation age. Okay, so low birth weight baby, we're all very familiar with this. They are between 1500 grams to 2500 grams. What I meant by this is if the baby is 2490 grams, that's still a low birth weight baby. Okay, that's why we're talking about grams, we're not talking about kilos. Okay, so it should be the baby should cross 2500 grams to be termed as a term baby, otherwise it will be a low birth weight baby. Then after that we have very low birth weight babies. So very low birth weight babies is between 1000 grams and 1500 grams. Extremely low birth weight baby is less than 1000 grams. Okay, very, very simple, just three classification. Then we have the small for gestation age infant. Okay, so this can be a term, this is applicable to both term or preterm babies. So you can have a term baby who is SGA or a preterm baby who is a small for gestation age. So if you plot the weight on the growth chart, it is less than 10 percentile for gestation. Okay, so that's how you classify it as SGA. If it's more than 10 percentile, it's called AGA, so appropriate for gestation age. If it's more than 95, it's a large for gestation age. All right. Then based on the gestation age, you have preterm babies, late preterm, and extreme preterm. So preterm babies, if they're born at less than 37 completed weeks. So if they're 36 weeks and 6 days, that is still preterm babies. Okay, they're less than 37 weeks. If they've crossed 37 weeks, only then they are term babies. So 36 weeks to 6 days is still a preterm baby. Late preterm is between 34 to 36 weeks, and extreme preterm is less than 28 weeks. Okay, I hope I'm clear about this. You can take a screenshot if you want. Okay, then care about small babies. Where do all these small babies go? Okay, so the different levels of neonatal care, the different grades or level as you call it. You have level 1, level 2, and level 3. So level 1 is where 80% of the newborn that are born will fit into. All right, so this is who are these babies? So babies who are weighing between more than 2000 grams and more than equal to 37 weeks. So they could be term babies but small. Okay, IUGR babies or SGA babies. So these are the babies that will that will need a level 1 care. All right. So who can look after them? So any basic healthcare professionals, either at home or PHCs, if they can visit the mother at home, you can do level 1 care. All right, or in the PHC. So what you do, basic care at birth, we've already talked about this. The routine care, we've said about that. Okay, maintaining temperature, breastfeeding, providing warm, maintaining asepsis. So these are the basic care that you provide for a baby in a level 1 neonatal care. All right. Then level 2 care. Level 2 care, basically whatever the amount of infants or newborn that you have, only 10 to 15% of them will be requiring level 2 cares. So who are these newborn who will require level 2 care? So newborn who are low birth weight, okay, and very low birth weight babies, basically. So between 1500 grams and less than 2500 grams or 2000 grams. Beyond this, we can go to level 1 care. and gestational age between 32 and 36 weeks. So preterm babies, not extreme preterm, just preterm babies 32 and 36 weeks, who can take care of these babies. So you need a pediatrician, so you need trained nurses who can take care after newborns. Okay, so this is level 2 care. Where is this care given? At the first referral units, your CHCs, your district hospitals, teaching institutes, and nursing homes. These areas, wherever you have maternity and child services, should be able to take care of these infants between 32 to 36 weeks and between 1500 grams to 2000 grams. So what care are they giving? They give, again, the above cares, like they give basic care at birth, they get warm, they get asepsis, they promote breastfeeding, plus these centers should also have equipment for neonatal resuscitations and facilities for maintaining of thermoneutral environment. That means they should have warmers or warmers in their facilities. Okay, and besides that, should also have facilities for IV drugs infusion, for gavage feeding or nasal tubing feeding, for phototherapy and exchange blood transfusion. Then the last is your level 3 care. So basically here, only 3.3 to 5% of your newborn will qualify for this care. All right, so if you have like 100 newborn that is born, maybe only 3 of them will require level 3 care. All right, so babies that are very preterm babies, less than 32 weeks, or extreme preterm babies, babies who are very low birth weight, less than 1500 grams, okay, or less than 1000 grams, all those will require level 3 care. Now, who is eligible to give level 3 care? So any Apex Institute or Regional Institute of Excellence, or all those centers will qualify to give level 3 cares. Okay, now who do you need for this? You need a neonatologist who specializes in neonatal care, neonatal intensive care, and skilled nurses trained in intensive neonatal care. All right, so this is NICU care. So any skilled nurses who knows about neonatal intensive care will be able to work in level 3 care. All right, so these are all level 2 and level 3. You need skilled nurses and skilled doctors. As a level 1, junior resident or a medical officer will be able to take care of these children. Then the care given is all of the above. All right. Besides that, they also have facilities for centralized oxygen, centralized suction, for ventilators and servo control incubators. Okay. So most of the areas they have level 2, like they club these together. So level 2 and level 3 care. So some area has a level 3 care will also provide care to level 2 babies as well. All right. Okay. So if we go this accordingly, I think a lot of the gaps, a lot of the what do you call the load on other centers would be like quite lessened if you follow these cares for small babies accordingly. Then what are the things you do? How do you care for small babies? Besides the essential newborn care that we've already talked about, what you do is you identify the mothers at risk. Okay, this can only be possible by your antenatal care, which we've already discussed in detail about yesterday. So identify the mothers at risk, identify where she needs to deliver, whether she needs to deliver in a place at level 1, having level 1 neonatal care, or level 2 or level 3 care. All right, so you can identify the place where she can deliver. Even if she does not deliver in that place, it doesn't mean she can't have a right to this care. So wherever she is delivered, you assess properly whether she needs a level 2 care. If you have to transfer, so assess whether she needs a level 2 care or level 3 care, and then maintain warm chain during transportation. All right, so maintenance of warmth and prevention of hypothermia during the transport level. I mean, sometimes what happens is you've done everything, or you've done all the essential newborn care at birth, at delivery, but transportation, I mean, this is something that we are still lacking in, which we are still weak at. But maintenance of temperature, so many times you've had babies coming to us with temperature of 32 degree or less than that, or not recordable. Okay, so this is something that can be prevented very easily by, I mean, India is known for so many innovations for maintaining temperatures. So KMC is one of them, and using other innovative locally available, we don't have a transport incubator, using all those innovations to transport the babies. Okay, then other cares of newborn small babies is feeding. Anybody who has worked with in SNCU or worked in NICU, you know, feeding is a huge task. It's not so easy. Okay, this is something that requires adjustment, that requires expertise. So many things is involved in feeding a small baby or a preterm baby. So we use what is known as MEN, or trophic feeds. Okay, this is minimal enteral nutrition. So based on the weight of the baby and the gestation, we decide whether we start with IV fluids, or we start with breastfeeding, or cup feeding, or we start with NG feeds. So let's look at this first column first. So the baby is preterm, less than 30 weeks, less than 1200 grams. We initially give IV fluids first. If the baby is hemodynamically stable, then we give NG feed, we give MEN, okay, minimal and enteral feeding or trophic feeds. And then slowly after 2 or 3 days, as we graduate the feeds and the volume and the frequency as we increase it, then we can stop the IV fluids and then go fully on NG feed or gavage feed. And later on, as the days progress, the baby increases. Once the baby is 32 to 33 weeks and the sucking and the swallowing reflexes is present, then you can start cup feeding. Okay, so once the baby is 34 weeks, you know that the sucking and the swallowing reflexes are coordinated. So you can try cup feeding or spoon feeding in this case. And once you've monitored them and the feeding is adequate, the baby is gaining weight, then you can finally graduate to breastfeeding. All right. Then the second category, between 30 and 34 weeks, 1200 to 1800 gram babies. A lot of babies come with 1500 grams, 1600 grams. So in these cases, again, we want to start with NG feed, again, depending on the availability of breast milk or what happens to the mother. So this is what we start immediately, okay, maybe half and half IV fluids, half NG feed. Then we slowly graduate to cup feeding and then breastfeeding as the time progresses. Then for slightly bigger babies, slightly older ones, so more than 34 weeks, more than 1800 grams, you can directly breastfeed them, okay, monitor the other vitals and the sugar, or you can do just express breast milk and give via spoon. And then as they grow older, then you can just continue on with breastfeeding. And what else you can do is you need to monitor, okay, so monitor during feeding and during hospitalized stay. So feeding monitoring, again, this is a job that we need skilled nurses to do. Nurses who are like, again, who worked in neonatal intensive care unit, they're used to doing this, they know what to do, okay. So you need to monitor the feed, you monitor for feed intolerance, you monitor for any altered feed, aspirate, okay, you need to do this because you need to detect NEC or anything or the other complications. Then you have to continue monitoring other vitals as well during the entire hospital stay. And then once you've established a feed, you need to see whether the milk that the baby is getting is adequate or not. That means whether the baby is gaining weight. Okay, so most of the time with preterm babies, they do not gain weight. They take a long time always. They might even lose weight. So what we do is you can fortify the milk. There are lots of fortifiers, human milk modifiers. You can use that. You can use MCT oils. You can use those fortify the mother's milk to help in weight gain. Okay. And last but not the least, small babies are also entitled to immunization, routine immunization. So your BCG, OPV, and then your hepatitis B. Before discharge, they should get your 0 dose of hepatitis B. All right. So this is all about small babies. And let's talk about danger signs. So danger signs is like something you need to know so that you can also see it when you are looking at the baby, when you're examining at the baby, and also something that you need to tell the mother as well. Okay. So these danger signs, like in newborns, they won't be able to say that they're sick. All right, so these are the only thing you know whether the newborn is sick or not. Okay, so they're very good indicators of a serious illness in a newborn. So the first thing is just temperature, whether the baby is hypothermic or hyperthermic. Okay, the more serious indicator is hypothermia. All right, so if the baby is very cold to touch or having a fever. So this is again very sensitive indicator that the baby has an underlying illness. The second one is poor activity. If the mother says the baby is not feeding well, okay, is refusing to feed, okay, that is a danger sign. That is a red flag sign. Please intervene and start investigating this baby. Then third is your respiratory rate. You already counted the respiratory rate, isn't it? If it's more than 60, you have to count this for 60 seconds. Okay, if it's more than 60 per minute, there's chest retractions, if there's grunting, any signs of respiratory distress, this is a danger sign. Then you can also teach the mother to count the respiratory rate. Okay, teach the mother how to count it. Then another thing is apnea or cessation of breathing. So if the baby is not breathing for 20 seconds. Okay, most baby will have rhythmic breathing. Okay, sometimes they breathe, they stop, they breathe again. Okay, so if you notice baby, most of them has this kind of breathing. But apnea is when it crosses 20 seconds. For 20 seconds, the baby is still not breathing. What else is it? Sometimes it may be less than 20 seconds together with desaturation. All right, so that is apnea. All the babies having labored breathing. Okay, the babies having your head bobbing, having recessions, okay, having retractions, all that. Those are again danger signs. Cyanosis, any discoloration in the lips and tongues, okay, that's cyanosis. Jaundice involving the palms and soles, those are danger signs because they can cause this bilirubin can cross the blood-brain barrier and can cause bilirubin encephalopathy, okay, and neurological sequelae later on. any abnormal body movement or convulsions. Remember, in newborn, they don't have seizures like how adults have. They have very subtle seizures, they're called. So they can be like lip smacking. Okay, newborns, normal newborns do not lip smack. All right, so they might just have lip smacking, or they can have, like rowing movements. Their hands will be rowing, or they can have cycling movements with their legs. So those are the seizures that newborns will present with. So any abnormal body movements, any bleeding from any side, so basically the cord or the fontanelle or any other side. All right, and if the baby has any diarrhea, vomiting, abdominal extension, that's again danger sign. Any umbilical discharge or skin boils, these are all the danger signs. If you know these, there are 10 of them. If you tell the mother about all these danger signs, and if all of you remember them and know what to look for them, you know that this baby will need further intervention. All right, very simple. Okay. Then after that, then timing of discharge. You need to know when to discharge this baby, isn't it? So what should you do? There are certain criteria before discharging a baby. Okay, a normal baby. We're not talking about a preterm baby or a high-risk baby. We're talking about a normal baby who's there in the postnatal ward or who just requires discharge. So you need to make sure that the routine formal examination has been done. So after delivery, whether the baby has been examined from head to toe or not, whether this has been documented. Okay, that has to be done. And the baby has received immunization, all the birth immunization, BCG, OPV, and Hep B. And make sure that the mother is confident and trained to take care of the baby. There should be no significant jaundice and no other significant illness requiring observations. And make sure that the baby is breastfeeding adequately. Okay, what do you mean by adequacy? Okay, the adequacy means sometimes the mother will say, my milk is not coming out. Okay, that's the most common complaint that we have. All right. So remember that the colostrum, I think all of you know that the colostrum comes up for the first 2 to 3 days. Okay, so the heavy milk output will come out after that. But the colostrum, the energy is so dense that even 1 ml of that is equivalent to 10 ml of normal milk. All right, and the baby's stomach capacity is very small. It only take the way breast milk is designed is like it's designed to feed, like to fulfill the baby's requirement or energy requirement. Okay, so the first few days you just get colostrum and that's enough for the baby to survive. All right, so adequacy of feeding can be determined by passage of urine, that is 6 to 8 times in 24 hours. All right, the baby is sleeping well after feeds for at least 2 to 3 hours, and there's no excessive weight loss. You will have weight loss for the first 3 to 4 days, but not more than 10% or 12%. And then the mother has been counseled regarding routine newborn care, okay, and about the danger signs as well. Mother has been counseled about that, how to take care of the skin, the eye, the cord, how to breastfeed, okay, if she has any queries that has been answered. And then follow-up advice should be communicated very clearly to the mother. So only when you've ticked all of these, then you can discharge the mother. All right. So what I'll do is, if I do I have time, Manuka?
Actually, we are a little bit ahead of time because still we have 2 more presenters.
Okay. So anyway, I think I'll end my session here because what I've done next is the basic newborn resuscitation algorithm. Okay, this we've already covered the first one. Okay, this also we've already covered. This also we've already covered. This also we've already covered. Now what we have left is, after you've done initial bag and mask ventilation, if the baby is still not breathing, okay, you've already done bag and mask. For the first 1 minute, you finish your first golden minute. Now you need to call for help. Now you need another second person who's trained in neonatal resuscitation. So call for help. In the meantime, continue bag and mask. Don't leave the baby and the mask and call for help. Okay, ask somebody else to help. All right. Then once you've done this, once you finish, continue bag and mask for another 30 seconds. You assess the heart rate. The heart rate is more than 100 per minute. And the baby is still not breathing, continue bag and mask. Okay, if the heart rate is not if it's less than 100, then you need to, where am I? If it is if it's less than if it's not more than 100, so less than 100, you can intubate the baby, start chest compression and medication if required. So this is basically what the algorithm is all about. All right, but let me tell you, for resuscitation, you don't need anywhere beyond. How can I go back? For resuscitation, you don't need beyond the initial positive pressure ventilation. Almost 85. If you look at newborns, 85% of the newborns don't need any resuscitation other than the initial steps like drying and routine care. Okay, they don't need beyond that. Now another maybe 5 to 10% will require just the initial positive pressure ventilation. Very few, less than 5%, maybe 2 to 4% will require chest compression. Okay, so almost 97-96% of the newborn will require only up to the step that I showed you, like the positive pressure ventilation. All right, so if you can do only that much, you'll be saving so many newborns. Okay, so I hope I'm clear. Like the Indian Academy of Pediatrics all over India, even in Meghalaya, we are conducting a basic neonatal sustain program course. It is free. We do it for all healthcare workers who are working in the delivery rooms, and we will contact. Maybe we can inform Nanuka if we have any such sessions in the future. And all nurses, doctors who are directly involved in the delivery of the baby, for whether from obs and gynae and anesthesia, will encourage them to kindly join the course. So with this, I end my session. Thank you so much.
Thank you so much, ma'am, for the wonderful sessions. I think I've got so many questions in the YouTube also. So we will take up the questions after these two sessions. I'll request all the participants to stay back. We will answer your queries, okay? And in YouTube also, I've seen approx 60 participants are there. So I'm requesting all the participants who are joining through YouTube, please fill your registrations detail, because I have shared a link in live chat box only. So please fill your these things details also. So without much delay, next I would like to request our next presenter, Ms. Haitnelli. She is a nursing officer and she is going to present role of nurse in maternal and newborn care health during COVID-19. Over to you, Sister Haitnelli. Yes, you can unmute. You are muted. Haitnelli is co-host. Yes, sister, you are co-host. You can share your screen. Yes, you can unmute yourself. You can unmute. Okay. Yes. Yes, you are audible now. Yes, you are audible.
About my screen.
You can share your screen from down. You want us to share the screen? No.
Is it visible?
No.
Is my screen visible?
No. You can share from down. You just see the at low bar, you can see the share screen in a green color bottom. So you can click there. Or you want us to share the screen?
Yeah, you please share it for me.
Okay, sure. Four. Sure. Our screen is visible to you?
Yeah, it's visible.
Okay.
Yeah, it's visible.
Okay, thank you. You can go ahead.
First of all, I would like to thank the organizers for giving me this opportunity. And then since we are short of time, we'll just come to the topic directly. As we all know, the primary role of a nurse is to advocate and care for individuals and support them through health and illnesses. And there are some general roles which include recording of medical history and symptoms, collaborating with teams to plan for patient care, advocate for the health and well-being of patients, monitor patient health and report signs. Next, the administering medications and treatments, operate medical equipment, perform diagnostic tests, educate patients about management of illnesses, and provide support and advice to patients. Next, as we all know, this COVID-19 pandemic is posing considerable challenges to maintain the provision of high quality, essential maternal and newborns health services. And most of the pregnant women and the mothers with newborns, they experience difficulties accessing all these services, mainly due to transport disruptions and lockdown measures. And some of them are reluctant to come to the hospitals to the health facilities, mainly due to fear of infection. Even with all these problems also, we have to make sure that, the next slide, please. Even with all these problems also, we have to make sure that all the pregnant women, including those who are suspected or who are confirmed COVID-19, they should attend antenatal care visits. And we have to make sure that they're delivered with a skilled healthcare provider, so that they get a healthy outcomes for both themselves and for the newborns. And given the vulnerability of newborns during the first days of life, postnatal care services for mothers and their babies must continue to be prioritized. Next slide. And the CDC have also issued certain guidelines for providing maternal, neonatal, and child health services during this COVID-19. They have laid down 4 steps. We just see in a short in the steps which they have laid it down. First step is determining the pregnancy status of the lady. So a lady might be discovering her pregnancy either through a regular health checkup, which is conducted by the ASAs in the community health centers, or she might discover that she is pregnant by her own, and either the ASHA directed her to go to the health facility, or the woman itself went to the health facility directly. There, what will happen is we have to perform the antenatal and neonatal care, and we have to do the COVID-19 assessment and register the woman in the pregnancy register, or if it is in a community health centers or the sub-centers, they have to be, we have to forward it so that the surveillance or the follow-up can be done. Then during those time, if the woman develops COVID-19 symptoms, she has to go to a designated treatment center for testing. Then for continuation of ANC, either the community health worker, that is the ASHAs, provide the ANC, or she can go to the hospital directly itself. And then we have to tell her about the modified COVID ANC schedule, because we have ANC has been minimized to only 4 visits. So we have to fix all those days with her, and then we have to advise her to stay at home until delivery. And during those antenatal periods, if the woman develops COVID-19 symptoms, she has to go to the designated treatment center for testing again. And the third step is delivery. The lady might go to the sub-center for delivery, and from there, if anything happens, she can be referred to a facility where she can avail BMOC, CMOC facilities, regardless of the COVID-19 status. Once she delivers the baby, then she has to. Once she delivers the baby, she can be discharged from the hospital. And then discharging from the hospital also, it has to be done in such a case that once the symptoms of COVID-19 has subsided, only she can be discharged from the hospital. She should be advised to stay at home, and we have to teach her about the home care of the child. And then during the during the postnatal period, if she happens to develop any COVID-19 symptoms, she has to be again referred to a designated treatment center for testing. Next slide. The UNFPA have also issued certain guidelines regarding the maternity services, and they have also emphasized that maternity services should be prioritized as an essential core health services. It doesn't mean that we should not ignore the other problems also. And then maternity services should, maternity care providers, whether they are in the community health settings or whether they're in the hospitals, they should be protected, and they should be prioritized to continue to provide care to the childbearing women and their babies. And we have to make sure that as a maternity care providers, we have the right to full access for all the PPEs, and then sanitation and safe and respectful working environment. Next slide. So they have laid down some general protective measures, which is applicable to everyone who comes in contact with the patients. Next. So we have to make sure that all the staff and the patients have an access to hand washing facilities and be encouraged to do so as they enter the health facility. If we don't have at least what we can do is we have to ensure there is a supply, and we have to ensure there is a supply of clean water, even if we have like at least a bucket of water that has to be filled every time. Then that has to be in every location or in every room where the staffs are working, or it might be in the waiting area. Then the next is we have to, as a nurse, we have to ensure there's the simple soap is available at every wash station, and the clean cloth so that we can use it as a towel for drying our hands. Or if it is not, if instead of towel, if it is possible, we can use like tissue just to wipe it and then throw it away. Then with midwives providing direct patient care needs to wash their hands with soap and water frequently. And whenever we wash our hands, it should be at least for 20 seconds. We have to wash our hands before we come in contact with any new patient and then perform physical examination. Then we have to wash our hands again after in contact with any surfaces. And after finishing washing of hands, we can go to another patient for the next care again. Then we should avoid touching the eyes, nose, and mouth. Then we advise everyone, that is our staff members and the patients, about the respiratory etiquette. Like if they want to cough, they have to cough using a tissue, or they can use their elbow, or they can use their hands, and after that they have to wash their hands properly. Then when we are providing care, we have to make sure that we maintain a minimum distance of 2 arms length as much as possible. And after examining of any patient, we have to wash our hands again. Emphasis is very much laid down on hand washing, because it is a basic principle for reducing infection and prevention of infection too. Then whatever surfaces which is used by the patient and the staff, it has to be sprayed with a cleaning product. We can use like 5% sodium hypochlorite, and then we have to wipe it down with a paper towel or a clean cloth in between the patients, and then it has to be followed by hand washing again. Next. And here what happened is, let's say the patient has these are the general principles. So we have to before providing any kind of care, we have to do triage and screening for COVID-19 for all the pregnant mothers, whether they rescreening for COVID exposure and symptoms needs to be undertaken for all women, whoever is presenting to the health facility, because we don't know who is positive and who is not they might be positive without any symptoms. Then it's not only the women we have to screen, but the accompanying persons also has to be screened. And then we have to ask them about their general well-being, if they have any medical conditions like cardiac problems or post-TB, all those things, and whether they have fever or any respiratory symptoms. Then this might, the triage or the screening, it might be done in the hospital or it might be done in the sub-centers. So what happens is we have to make sure that there is a pathway, a referral pathway, to provide emergency transport to avail the BMOC and CMOC services. And whenever a transport is needed, we should always make sure that wherever we are supposed to transfer, if it is from a BMOC, and we have to inform the CMOC facility about transfer of the woman in advance. Because what happens, like as yesterday, Ma'am Wansalan has said, there is a wastage of time. Like they'll just take the patient to a CMOC facility, and if there is no bed, it's just a waste of time. So it has to be informed in advance. Next slide, please. So what we have to do when we are preparing for emergency transfer, especially this is mainly for the case of those patients who went to the sub-centers. So we have to prepare the transport equipment, and we have to prepare the drugs in anticipation of medical emergencies, because anything can happen on the way. Then whenever we are transport like cardiovascular collapse or hypertension, then all the transport staff, they have to wear a PPE, and they need to have an N95 mask. And if it is not possible, if it is not available, at least a surgical mask has to be worn. Then we have to avoid unnecessary breathing circuit disconnection during transport. If in case we are, if the patient needs oxygen and all, so we have to avoid unnecessary disconnection of all those things. Then what do we do with the transport vehicle? The transport vehicle has to be clean, and it has to be disinfected internally. Why we are emphasizing on this is because if the person is transferred from the sub-center to a higher center, mainly it is a rule that the staffs have to accompany the patient. So it is our responsibility as a staff how we are supposed to take care of the transport vehicle. So it has to be clean and disinfected internally prior to transfer from BMOC to CMOC facility. And when we arrive at the CMOC facilities, we have to remove our PP and it has to be disposed as per the hospital protocols. And then we have to wash the hands. And when we are supposed to go back, then we have to don a new PPE. And when they reach the BMOC facility or when there is their own hospital, they have to remove it in the nearest area, like at the ambulance bay. And whatever equipment is used during transportation, it has to be clean or it has to be sterilized as per the facility protocol. Next slide, please. So still continuing with the triage and screening, the women, whoever is suspected with a COVID-19 has to be provided with a face mask and they have to be treated in a dedicated treatment area separate from other patients wherever possible. Because the next is all the maternity care providers should always have an access to a PPE. And then during any episode like during any episode of patient contact, the care provider should always follow the infection control practices like hand washing. And then we should always clean the surfaces, whichever we are coming in contact with we are coming in contact, as well as the surfaces which the patient is coming in contact with. Then in addition to all these practices, we should know as a nurse, we have to maintain a physical distance of 2 arms length whenever it is possible. And even that 2 arms length, we have to maintain it within ourselves, within the health staffs only, even if the patients are not present also. Next slide, please. We'll come to the antenatal care. As per the guidelines which is laid down by the UNFPA, antenatal care has to be provided away from the general patients who are presenting to the outpatient care, even like it, because it might not be related to the midwifery care needs also. And we have to provide health information at the beginning of the antenatal care regarding social distancing during the clinic sessions, because it is the first time they're coming, and we have to provide all this information so that the next time they come for the visit, they will remember it, and then they will maintain the distances. Then we have to educate them about the prevailing viruses, such as the symptoms, then like warning symptoms, what can happen, as sir has already discussed in the previous classes. What are the warning symptoms that we have to educate them about, how they have, if they happen to have the symptoms, how are they going to isolate themselves at home, and the emergency signs. And then we also have to provide information so that we minimize the women's fear about the impact of COVID-19 and encourage ongoing contact with all the health services. And we have to tell them whom they have to contact if they happens to have all those kind of problems. Then the next thing is we have to restrict the attendance for ANC, and we have to include the woman and only one partner who is asymptomatic whenever they come for attend. We should not allow so many people to accompany the lady when she comes for antenatal visits. And then we can continue with the physical contact and the clinical examination as normal as during ANC visits, but we have to pay extra attention to the infection control measures. We have to ask the women also to wash her hands upon arrival to the waiting area, clinical rooms, and before leaving the clinic, she has to wash her hands again. The same thing applies for the healthcare provider also. Next slide, please. Then we have to schedule the antenatal care visits. As we have said, it is as much as possible, we have minimized it to 4 visits only. And while with these visits, we have to make sure that the women is getting enough supply of iron, folic acid, calcium. And then we have to make sure that with each visit, we can arrange for the investigations like ultrasounds, routine investigations, blood tests, and all those urine tests, whatever investigations has to be done, we should try to arrange it accordingly for the next visit so that she doesn't have to come to the clinic unnecessarily. Then the specific content of ANC remains unchanged in the context of COVID-19. However, maternity care providers, we have to be aware of the increased risk of antenatal anxiety and depression and domestic violence due to the economic and social impacts of the COVID-19. What happened is anxiety. Anxiety may be due to fear of childbirth, or might be because, as we have seen, it might be due to lack of or due to poor social and financial support, and it might be also a case of some emotional abuse, which can be like the pregnant lady is being humiliated or insulted, or she is subjected to controlling behavior such as not being allowed to see the friends or family members, or not allowed to make any contacts with the other friends also. So we have to assess for all those anxiety and depressions also. Next slide, please. Okay, next slide.
Lynn, you want me to next slide?
Can you please come to the intrapartum care?
This one?
Yeah. Next is intrapartum care. So for all the women,
This one?
Yes, that one. So intrapartum, when the woman comes for delivery, just like the same procedure for ANC, we have to do a triage and then screening again for the lady as well as for the birth companions. Then the same infection control precautions, all these things has to be followed, and all the women have to be encouraged to call the health facility wherever possible in early labor, and they also have to inform the healthcare provider or the nurse if they have any kind of respiratory or any other COVID-19 related symptoms, so that they can assist them in further planning as well as for a potential referral. Because if the patient presented herself in the subcenter and if they are not able to take care of her there, they have to decide for a potential referral. And then whenever a woman comes for delivery, it is the responsibility of a nurse that we maintain the right, and we have to treat them with compassion, dignity, and respect. And we have to make sure that only one asymptomatic birth partner is allowed to stay with the woman. And if it is possible, we will allow them to stay with her through labor and birth. Next slide. Then how do we prepare the labor room? Because we are going to receive a patient who is who is suffering, who is COVID-19 positive. When they come to the labor room, it is not necessary that they present with all the symptoms. They might not have the symptoms also, but we have to give attention to the infection part. And what we have to do, we have to make sure that we have sufficient supplies of PPE, like masks, gloves, and everything in the labor room. And then we should always clean all the surfaces thoroughly with a spray and a clean cloth after any contact by the health personnel or the patient. And everyone should follow regular hand hygiene practices before and after examining of each patient. Next. The previous one. Okay, so for those women who are having symptoms which is consistent with COVID-19 infection, the same thing after trials and everything, if it is possible, we have to take care of that woman in a single room. And in that single room, she has to be isolated till the time of her discharge. And if a woman is presented with an acute respiratory illnesses, we should give marks to her during the whole duration of care. And if the woman cannot have an access to a single room, we have to find a way that we separate all those sick women from the well women, like putting them in one corner so that we reduce the risk of virus transmission from the sick people to the well women. Then the mode of birth, it has to be individualized. Just because a woman is COVID positive doesn't mean that we have to go for a cesarean section. Then care during labor should not differ from the usual. Whatever care we are giving to a normal pregnant lady who comes for delivery, the same care has to be given to a COVID-19 infected mother also. And then we'll have to maintain early fluid input and output chart so that we avoid the risk of fluid overload during delivery. And if an infected woman requires a cesarean section, everyone who is present in the theater should wear a PPE. Next slide. Next we'll come to the postnatal care. So for postnatal, whatever it is, we have to limit the number of visitors because of the pandemic. And whoever is coming to visit the mother or the baby, we should make sure that they follow the infection control procedures like washing off their hands with soap and water on entering and while leaving the room. And if they happen to come in touch with the patient or if they happen to come in touch with the newborn. Next. So how do we take care of mother who is infected? As till now, there is no evidence that a woman with symptoms which is consistent with COVID-19 infection needs to be separated from her baby. So whatever it is, regardless of what it is, whether she is positive or whether the mother is negative, we should make sure that they stay together. We practice rooming in. We establish breastfeeding within 1 hour of birth. Then we practice the skin-to-skin contact or the kangaroo mother care. And if the woman who is infected, she has to avoid contact with other mothers and the babies. And she have to undertake hand washing before and after contact with the baby, and she should consider wearing a mask when feeding, providing skin-to-skin or kangaroo mother care for her baby. Then routine cleaning and disinfecting of all the surface that the mother has had contact with should be undertaken at regular intervals. So even if the mother is COVID-19 positive, she can provide all the routine baby care to her own baby, like feeding, skin to skin, and then whatever is required she can do. But the thing is, she has to maintain the hand hygiene. Plus, she should wear a mask always, so that so that she can prevent the transmission of infection from herself to the newborn. Then breast milk from infected mother has been shown to be negative for COVID-19, so breastfeeding is not contraindicated. But if a woman is unwell to breastfeed her baby, we have to give her a breast pump so that she can express the breast milk. And the breast pump which we are giving to her, it has to be separated for her, and it has to be clean as per the infection control policies of the hospital. And then the breast milk can be fed to the baby. Then there are few neonatal infections that have been reported were acquired in the postnatal period, and the infants were not significantly unwell. So since it is already clear that it doesn't have much effect, so we should never separate the mother and the baby. Next. If the mother is not infected, we have to plan for an early discharge from the health facility. And we have to make, like, once she is discharged from the hospital, we have to teach her about the danger signs. Well, ma'am has already discussed about the danger signs which can be seen in the newborn. We have to educate the mother on all those danger signs. So if she happens to come across all those things, she can come to the hospital directly. And then we also have to, like, she doesn't need to come to the hospital. She doesn't need to come to the hospital for every visit. Instead, what we have to tell them, like, these days we have all those telemedicines. We can advise her to download the mobile health applications, and also she can go to the community health centers also, instead of being exposing to hospitals again and again. Then for all women, what we have to do, we have to tell them, we have to encourage all the mothers to breastfeed their babies. And then we have to assess for the postnatal anxiety and this depression, because it is very common for the mothers as well as for the fathers, for the new father, so to say. For them, they can have all those anxiety and depression. Then we have to arrange for a telephone or video follow-up for the postnatal period. The next slide. Okay, how do we care of the babies born with suspected or confirmed COVID-19 mothers? We should encourage mothers. We should encourage the babies to stay with the mother in the postpartum room. And then if it is possible, we have to arrange for a private room. We have to advise the mother to wear a mask. She should follow all the hand hygiene before caring of the baby, skin hygiene before breastfeeding. After each and every breastfeed, she has to clean the breast. And we should make sure we have to make sure that we are keeping the infant and the mother 2 meters away when they are not providing direct care, that to protect against droplets due to coughing. Then, if it is possible, a separate newborn care area with caregivers should be made available for women who are unable to care for the infants due to the symptoms or upon the request of the mother or the family to prevent COVID-19 transmission to the baby. Then, well, baby should be discharged early if possible after proper risk assessment has occurred. So before discharging the baby, we have to see that the baby doesn't have any complications, the baby is healthy, and the baby is fit for discharge. Next slide. So just would like to conclude our next slide, please. Would like to conclude our topic by saying that since the pandemic is going to continue, the nurse responsibility is that we can take steps in helping the pregnant women and mothers with newborn by screening, referring, and listening. Screening in the sense we have to screen all the pregnant women for COVID. We have to screen them for any disorders, mental disorders related to pregnancy, and whether they have a chances of developing postpartum psychosis and all. And then once we have screened the mothers and then we find out that they have some problems, we have to refer them to the appropriate referral centers depending on the screening. Like if we have evaluated that the mother is having some kind of mental problems, then we can refer them to a psychiatrist and all. And then once the woman, as we have said, the pregnant woman, they will be coming for antenatal visits. When they come for the antenatal visits, we should be listening to them. We have to make time to talk to the woman at its prenatal visits, at its prenatal appointments, like if they have any specific concerns, if they have any anxieties, and we can discuss with them about the birth plans. We can discuss about the changes in the hospital policies. Like as we have said, once they come for antenatal, they have to be, we have to do triage, screening and everything. And after that, when we have to educate them that when they come for the intrapartum care, what all procedures she has to follow, what she has to do, on all those things, we have to educate her so that when she comes to the hospital, she doesn't have any problems. She is like well versed with the hospital policies. So maintaining a safe care for women and newborn during the COVID-19 pandemic is critical, and rapid action by nurses who provide maternal and newborn care will help create an atmosphere which is conducive to best practices in collaboration with other multidisciplinary teams. And these are the references for my today's presentation. And thank you everyone for the patient listening.
Thank you, Athleen sister. So now we are already almost 1 hour ahead of the time. So we have one presentation. So today we are not able to do the one presentation. So we wanted to do whatever questions you have asked. We wanted to take up your queries and one presentations tomorrow at the same time. I think it is okay with all the participants. Because it's now, even if we discuss the questions, even if you do the presentation, I think it will not go inside your head. So I think it's better to do tomorrow. So I request all the participants to join tomorrow also. Tomorrow we will not have long. We have only one presentations left. So we will have one more presentations and then we will take up your questions. So we will have one more presentations on referral linkage and transportations, care of mother and newborn. And then rest we will do the discussions, whatever queries you are having today also, that we can take up tomorrow. So I think, is it okay with the Rosina ma'am, Mary ma'am?
Yes, Nanuka, I just saw one question, because the rest of the question, I think Sister Hatnehing has already answered most of them about feeding for COVID, positive mother or COVID positive baby. And we have a link. We had this talk on breastfeeding during COVID time, during breastfeeding week. Maybe Nanuka, you can share that link. It's
Yes.
there on YouTube only, done by Japaiko. So maybe you can go through that if you want to clear your doubt about breastfeeding in the COVID time.
Okay.
Okay, and there's only one question that I can see. There was a dose of vitamin K. I think I've already mentioned in one of the slides. For less than 1500 gram, it is 0.5 milligram intramuscular. Okay, it's given on the anterolateral aspect of the thigh. And for more than 1.5 kilo, it is 1 milligram. Okay, those are the only two doses that we give of vitamin K. Other than that, I have not seen any other questions.
Other questions, like three more questions is there in YouTube also. They have wrote down in chat box of YouTube also. So three more questions are also there. So
If you can tell me, maybe because most of them have already been covered,
okay.
I'll just we can go through them quickly.
So ma'am, one question is like, can we start a PCM for baby if the temperature is 99 degree Fahrenheit?
No, we don't need a temperature of 99 degree, okay? We don't need to start paracetamol. Only if the temperature is 100.4 degree and above. Then because normally babies do get warm in the evening, they have this diurnal variations in temperature, so do not start.
Okay, ma'am, the next question is like, if baby is born with a COVID positive mother, so just need to do do the test need to do for the baby if mother is born with a COVID positive?
That depends on your hospital protocol. Okay, if the baby is sick, the baby needs admission. If the baby is suppose a preterm baby needs resuscitation, needs to go admitted to an ICU or SNCU, then yes, we do a CBNAT for that baby. Otherwise, if the baby is stable, this is what we do in our hospital. Otherwise, if the baby is stable, depends from hospital to hospital. Some hospital keep these babies in a separate area of the SNCU. In our hospital, if the baby is fine, we keep the baby with the mother and we repeat it before the discharge. So anytime next 24 hours or so, we do the RT-PCR for the baby if the baby is fine. But at any time if the baby requires admission, then we do a CPNR and we shift the baby to our NICU.
Ma'am, one more question is related to this. If the baby is tested positive, if they have done a test for the baby and turned out negative, so baby will send to the home or baby will keep with the mother in ward only or wherever mom is there?
No, if the baby is negative.
Negative, yes, but mother is positive, baby is negative. So baby will send to home or will keep with the mother?
It depends on your hospital policy, because what happen is if you have space, because see, the thing is we want to continue breastfeeding. Okay, so it depends on your hospital policy and where the baby is. Mainly from our perspective, we need to ensure that the baby will get breast milk, whether it's the mother's milk. If the mother can express and the relative have means to carry that milk to their home, okay, or if the baby has if there's a vet nurse or other members in the family who are feeding, then you can send the baby home. Or what you can do is, again, depending on the hospital, if you have beds in your SNCU or beds in the ward, you can keep the baby there. And then you can give the express breast milk from the mother to the baby.
Okay, yesterday also I think in one presentation ma'am has mentioned like with if unless and until if mother is not well, not able to breastfeed their baby, then only you can separate the baby. Otherwise, as per the WHO protocol, as much as possible you just keep with the mothers only.
Yes. Even in here, even in Nigrim, so far we've been lucky to not separate the mother from the baby. So far, wherever the baby is, mother is, whether the mother is in level C or level B, we've always been keeping the mother and the baby together. So as much as possible, do not separate them.
Yes, thank you so much. Only this much questions are there related to your topic, ma'am. So tomorrow we'll do the discussions with other topics which is left, and also we'll do the one presentation. So timing will be the same and link will be the same. Timing will be the 3 p.m. only. So we'll do 3 to 4 p.m. only 1 hour, and then link will be the same. So I request all the participants to be there tomorrow also. Sorry, because of time we couldn't cover one topic. Already we have taken here 1 hour extra time. So thank you so much for this. And then we will see you tomorrow. And then post-test also I will share you tomorrow itself.
Okay, thank you so much, Nanuka. Thank you so much to all the participants for staying until the end. Really encouraging to see so much participation, and I hope these sessions were helpful. And please check the link for the breastfeeding. We've done it very well, I think. I don't know. As per my opinion, that's a good session. So please check that. Nanuka will share that link with you. Maybe I can share in one of the group as well.
Yes, ma'am. I'll share in the WhatsApp group, and also wherever this live screening is going on, there in that account only you will see all the
Oh, yes, yes.
videos related to NIGRIM. So you will find out there only in that account only. So
I
thank
think
you,
those
and
are
see
really
you
helpful for
tomorrow.
those who have not been able to join then, no?
Yes, so PICU, ICU training, all the training is there in that account. So thank you so much, and see you tomorrow. Hope all will join tomorrow
Okay.
also.
Thank you, everyone.
Rosina.
Bye.
Thank you, Rosina ma'am. Thank you, Hatling sisters, Hatling sister, Vijay sir, and the Bhupen sir. I'll request to be there tomorrow also for the discussion.
Thank you, Nanuka.
Thank you. And thank you all the participants. See you tomorrow, same time with the same link. Thank you all.
Mm.